Good afternoon, everyone, and welcome to this governing body meeting for South East London CCG in public. I'm John T, and I have the privilege of chairing the CCG. You're all very welcome, and what I wanted to do in the first instance is we just to call out, I think, a couple of sort of processy issues. What I might do, Christina, is just hand to you just to describe the way in which we'll be interacting with members of the public during this meeting, and that will just ensure that we kind of clarify the next steps in terms of questions and so on.
Sure, absolutely, John T, no problem. So yes, welcome to anyone who is watching online. We do have two Q&A sessions, one at the beginning, which we'll come on to after we've gone through the opening business for largely pre-submitted or initial comments. The Q&A function would then be closed until slightly later in the meeting. At that point, it'll be reopened, and then we have another public forum question towards the end of the meeting as well. So hopefully it's clear how you can ask the questions. You might not see them necessarily be published, but we will endeavour to get them in either of the two sessions, or if we don't respond to them in the sessions, we will be providing with the minutes responses to those questions as well. So yes, please do ask questions and we will do our best to answer them as thoroughly as possible.
Thank you, Christina. That's really helpful. And just in terms of introductions, because we have nearly 30 people on the governing body, I'm not going to attempt to get everyone to introduce themselves, or we won't have very much meeting time left. What I am going to ask is that if you are speaking, it would be very helpful just to ensure that those who are watching know your name and your role. So it would be very useful if just before you're presenting or asking questions, if members of the governing body could just ensure that they let people know their name and their role within the organisation. That would be very helpful. So as I say, you're all very welcome. I'm sorry we've had a slightly later start to the meeting than anticipated. I just wanted to check, first of all, any apologies that we have for the meeting, and I believe we have apologies from Professor Mackenzie and Dr. Desmuch, and actually I was going to say from Clive as well, but actually Clive's on. So I think those are the only two apologies that that we have. Is anyone else aware of any apologies? Okay, fantastic. And in terms of the declaration of interest, that has been shared with the papers of the meeting. Can I just ask whether anyone has any changes to make to their declared interests? Perhaps just indicate to me if you need that updated at this point. Okay, then we will assume that the register of interests is up to date. Obviously, if outside the meeting people's interests change, it's always important to ensure that that is constantly kept up to date. In that case, I just want to move to the minutes of the meeting of the 16th of July, and I wonder whether I can just ask people whether they are happy to accept that record of the meeting, or whether they have any concerns over accuracy and would like any corrections made. Does anyone have any corrections to be made to the minutes?
No. Great.
I'm picking up. So Farouk, you wanted to comment, I think, on something?
It was just to say that there were a number of duplicate entries in the declaration of interest. It's just for correction for future.
Fine. So if offline you could just clarify where those are so that that can be updated, that would be very helpful. Thank you. Really helpful. Okay, in that case, can we just move to the actions? Christina, there's only one action. Did you want to just pick this up?
That's right, yeah. There was an action at the last public meeting about doing a table or grid of various levels of delegation. Because we had we made some minor changes to the standing orders. We wanted to make sure that there would be no impact on any of that, but we will make sure that that action is completed in the early part of October, so certainly before the next public meeting.
Thank you very much, Christina. I will just ask all other members of the governing body just to go on to mute if they wouldn't mind, please, because there's a little bit of background noise, so it'd be helpful if we could. It's one of the challenges with the technology. Thank you very much indeed. If I could then go first to public questions, and Christina, you've explained the process. Would you like to just pick up this first session of public questions? We will of course come back to the public at the end of the meeting, but would you like to take us through this?
Yes, thank you, Jonty. So we had a couple of questions submitted in advance of the meeting. They came after the deadline, so we weren't able to provide a written response in time, but I was just going to go through them now and come to various members of the governing body to provide a verbal response. So the first question was from a Greenwich resident, Celia Watson, and I was going to come to Angela Barn to respond to this in a second. The question is about, she's registered at a GP practice in Greenwich and had approached them about getting a flu jab, and was told that they don't yet have flu supplies and aren't clear when they will receive it. So the question is, is there a challenge here, and is there a role for the CCG in responding to this? Angela, can I hand to you on this, please?
Yes, of course, and thank you. I've seen the question. My name's Angela Barn. I'm the borough-based director for Bromley and the South East London SRO for flu vaccination and also COVID-19 Gold. It's absolutely right that it's important that as many people get flu vaccination who are eligible for flu vaccine as possible, particularly when we may be looking at increased levels of COVID-19. Well, we are having increased levels of COVID-19. All practices have ordered their flu vaccine stock for this season with many months ago, and the delivery of flu vaccine comes in a phased way, so it doesn't all come at once, but all practices should know when their flu vaccine is coming. Now, in years gone by, we have had some delays in delivery. We're not aware of any delays in delivery this year. But what I would say is that the programme doesn't actually formally start in October, until October, the beginning of October. Now, it may be that some practices have already received their deliveries of flu vaccine and have already commenced the programme, and I think that's absolutely fine and right. But what we would say is ask Celia to get back in touch with her practice to ask when she might be able to make an appointment. It may be that the practice is waiting till they've actually got the vaccine before they do make the appointments. I think it is really important that somebody with a chronic condition has a flu vaccination. And of course, if a practice is in any difficulty with this programme, there is a lead person within the borough-based team that they can go to. We ourselves would be happy to speak to the practice if it would help them and see if there are any particular difficulties with this practice, but we haven't been made aware of any. So I think that's all really for the moment.
That's great. Thank you so much, Angela. Stay there, because actually the next question, I'm afraid, is for you as well. This is from Stephen Allen, a Bromley resident, and Stephen is asking about the move of eye services from the Princess Royal Hospital to Queen Mary's, and what has been done in terms of public engagement on this, considering, and he mentioned some potential concerns from members of the public about that move.
Okay, thank you very much. Well, just a general point, first of all, COVID-19, the pandemic has meant that some services have had to be changed at quite short notice. And as many people will be aware, the West Kent Eye Centre was right in the middle of the first floor of the Princess Royal University Hospital and surrounded by wards that were used for COVID positive patients. So it became clear very quickly that some significant changes had to take place to protect staff and to keep the service going. So at short notice, that service was moved to Queen Mary's Hospital. It's now being brought back into the borough, and some of the service, most of the service will. It is planned to be at Orpington Hospital and some clinics at the Princess Royal site itself. I think it's actually right that we try and ensure that the service is there for patients and that we increase access as far as possible. We are aware that sometimes when we've made these changes during the pandemic, that actually it's been for very good reason and has improved the service for patients. What I would say is that if we are thinking of making any major changes to any service, we would have to fulfil our requirements for consultation and engagement, and we do so happily and willingly. In terms of the West Kent Eye Service, we're aware that King's College Hospital colleagues would like to review the service and think about where they'd like to put parts of the service, and we are in discussion with them to look at what this actually means for the service, and we are engaging with our overview and scrutiny colleagues locally as part of that process. If we absolutely have to engage with patients, and I'm sure King's would agree that they would want to engage with patients, and we will undertake consultation as appropriate. But at the moment, it doesn't look like there are going to be such significant changes that we would change access for patients at all, and that's not our objective in all of this.
Thanks so much for that, Angela. Really, really helpful. Final question that we received in advance was about private healthcare providers, and I would like to ask Kate, our chief nurse, to provide a response to this in a second. This comes from Anne Garrett, and she said she's concerned. She has a partner with advanced Parkinson's and has been interacting with a private care provider, but had concerns about some of their infection prevention and control measures. She's unclear how to take that forward in the appropriate way. So her question was about the monitoring of private care services, particularly in COVID. If I could come to you, Kate, if that's right. I think you might be on mute.
That's not a good start, is it? So apologies for that, and thanks, Christina. So yes, I'm Kate Moriarty-Baker. I'm the chief nurse for the South East London CCG, and I would share concerns around this. So all home care providers are expected to follow the national guidance for the use of PPE for home visits. So that will include the use of gloves and masks and aprons for direct care, as well as all other IPC precautions. In terms of the monitoring of quality of home care providers, so the CQC is responsible for monitoring the quality of care provided by all registered providers. But in addition to that, depending on where the service is commissioned, local authorities and health commissioners, so the CCG, will have processes in place for monitoring the quality of care provision. In terms of taking your concerns forward, I mean, clearly the first point of call is to the provider, and I would encourage you to raise your concerns with that provider, and then in addition to that, you are able to raise your concerns with the organisation that is commissioning the care, if that is appropriate. Members of the public are also able to raise concerns directly with the CQC if they have any concerns about the care being provided by a registered provider.
Thank you so much, Kate. Really helpful response. So those were the questions that were received in advance. I'll hand to you now, John T, just for the last question.
Thanks, Christina, and thank you for taking us through that. So we have had quite a late question come in, but I think I feel it's important to include it. We wouldn't necessarily do that, but because it relates to an item for decision coming up on the agenda, I think it is important that we provide a response. Andrew, I'm going to ask you to respond. It's a long question. I'm not going to read it all out, but I hope I will do it justice. Essentially, it relates to the item that we have coming up on pathology services, and there are two elements to it. The first bit really is the extent to which the decision that we will be taking today should have been delegated to a particular borough-based board. So I guess the question is this a decision that ought to be delegated in some way? And then the second question is really about whether the decision will impact financially on Lewisham and Greenwich Trust in particular in relation to their pathology income. So I think if you wouldn't mind responding to both of those questions, it's important, I think, that we do that in advance of us taking this item for decision later in the meeting.
Thank you, Chair. So in relation to the first, I've got the benefit of the detail of the question. So it is, of course, true that those decisions related to delegated aspects of commissioning should be taken at borough-based boards, and this area of service is not delegated to borough-based boards and therefore is being taken at the governing body. The governing body paper that's making the recommendation is received from our Commissioning Strategy Committee. Commissioning Strategy Committee and the governing body benefits from representation membership from each of the boroughs across South East London. So that's on your first point. On the second point, I think the first thing to say, and I think the paper makes this clear, that we don't have a change in service for pathology for the South East London system. I don't want to misinterpret the question, but in terms of a risk assessment, the impact on the South East system, the service doesn't change, so I think that then becomes a moot point in that regard. In terms of, I mean, it's not for me to speak on behalf of the LGT Trust Board, of course, but in terms of this process, I think again the public paper reflects the longevity of the process, and this comes towards the end of that procurement. I've recently been reminded by Lewisham and Greenwich Trust that they've always been mindful of the risk that their role in providing this activity may not continue, because they were aware it fell within the scope of the South East London procurement. And on that basis, I'm making the assumption that this scenario has been considered by the Trust Board. And in addition to that, I think I'm also right in saying that the Trust is confident that the proposed pathology network with Barts and the Homerton would not become unviable if the Trust was not awarded this contract. I should say, however, that we have not taken that decision. It's one for the governing body in a moment. The question is one of detail, and I hope I've gone some way to answering it at this point.
Thanks, Andrew. That's helpful. As I say, I think important that we capture that, and thank you to Jane Andlick for posting that question. Christina, are there further questions for us at this point in the meeting?
No, that's all the questions. Thank you.
Okay. In that case, I'm just going to check. I'm not sure. Well, actually, I think Clive has just joined. Perfect timing. Clive K has just joined us. So we will be able to move on to the next item on the agenda. Just thanks again to those of you who have posted questions. As I say, we will come back to another public question session at the end of the meeting. The functionality will be turned off for a period, but we will turn it back on towards the end of the meeting so you can post questions, and Christina, again, I hope will kindly choreograph that so that we can make sure we cover as many as we possibly can. In the meantime, I did want to introduce Professor Clive Kay, who's the Chief Executive at King's College Hospital. Clive has also been leading the work to develop an acute provider collaborative, and what I wanted to do, we've always tried in our governing body meetings to invite providers to come and talk to us in a kind of, I guess, in a manner that allows us to understand how we can deepen our collaborative relationship across the system and understand some of the challenges that are faced by providers, but also ensure that we're constantly aware of sort of the opportunities that exist for us to support the system. And we have previously tended to have individual acute trusts come, but I'm really pleased that today Clive's going to join us and talk a bit about the work that's going on between our acute trusts to start to strengthen relationships and develop a collaborative between them. So Clive, on that note, shall I hand over to you? I know you've got some slides, so feel free to take us through those, and then the governing board may have some questions.
Yeah, absolutely. So John T, thank you, and Andrew, thank you. So I know that I've got a 25-minute slot, so I'm going to really try hard to stick to about 15 minutes because I would like there to hopefully be some question and discussion. So very quickly, I'm Chief Executive King's, as John has described, but it's in many respects not in that capacity that I really want to just talk you through the presentation today. It is as part of the newly formed Acute Provider Collaborative in South East London. Very quickly, just a bit of background for me. So this is so I can distance myself from all the previous history in South East London. I've only been here coming up to 18 months. It's been probably the longest 18 months of my life. I knew King's was going to be tough, but I didn't know I was also going to be facing a pandemic. But I have to say it's probably been about the most enjoyable period of my working life. And I think there's lots of great people down here in South East London, particularly in health and social care. And I think the potential is really huge. And I think we've sort of already started to demonstrate this, as you'll see, in terms of establishing this collaborative. So if I could have the next slide, please. So as I say, I am new to these parts. Even 18 months is still new. It's not necessarily new by King's Chief Exec standards, but it really is new to system working. And I know there's been quite a lot of work, good work being done in terms of the three providers in a range of specialties, but it's not been in a necessarily coordinated, sustained, robust, governance-led way whereby decisions, when they're made, are followed through, enacted upon, and all parties move forward in the correct way, the agreed way, for the benefits of patient care. So this establishment of the collaborative I'm just going to describe is in no way to denigrate what's been before, because there's lots and lots of great examples of partnership working, but this is really an attempt to put in place a formalised and formal structure around the way we work together, particularly but not solely as three providers, and I want to come back to that shortly also. So I think certainly these sort of collaboratives are developing across the country. I came down from West Yorkshire, we had one there. Manchester, Greater Manchester have had one for some time. They vary in terms of whether they just include the acute providers, whether they include, let's say, acute and mental health, community providers, or whether they also include all providers, and different parts of the country do it differently. And we, for now, have started just with the three acute providers, by which I mean Thomas's, Lewisham and Greenwich, and King's, including the Prue and the South sites. There's no doubt that our experience during COVID as three acute providers really cemented the need and really clarified the importance, I think, for many of us, of how important it was that we did establish some form of collaborative. I mean, I'm very, very pleased to say that not a single patient was sent out of South East London to receive critical care. We managed to care for all our patients within South East London by moving patients around the system in a way that optimised care for patients And I think not just in that area of care, but in a number of areas, would be clinical or non-clinical care. I think the three providers demonstrated with great support from the South East London system how important mutual aid is, and how working together as a system basically means that we end up being greater than the sum of our parts. And I think that started to really solidify, I would say, in people's minds that this is the future in terms of working closer together. So not long after we hit the peak, as we started to look at how we were going to recover across South East London, particularly as acute providers, it became very apparent that this was going to be much harder if we continued to work on our own, and certainly less hard, I can't say easy, if we worked collaboratively. And so we established the Acute Provider Collaborative around about the end of April, early May or so. And I'll just take you through on the next slide in terms of the way in which we work. So in many respects, the kind of the executive is that group of CEOs, those diamonds, the green diamonds in the middle, supported by a program director, PD, and those are the three chief executives of the acute trusts. And I just want to labour the point how important it is that those are the chief execs. We don't delegate that role unless, of course, we're on leave. But all three, myself, Ben Travis from Lewisham Grange, and Ian Amps, were there at every meeting. We initially set those meetings weekly. There was so much to do to get this established. We now meet fortnightly. We had another meeting this morning, and I think that demonstrates great commitment from all three trusts and all three chief executives. That chief executive group, the plan is to be supported by those groups sitting below, clinical strategy and ops, which by as the name suggests, will be supported by executive directors in those areas across all the three trusts. Likewise, the finance and estates group, and so on, as you can see. And certainly when we are fully up and running, all of those groups will be meeting on a regular basis. We'll be standardising the way in which we manage our workforce, deal with our finances, and so on and so forth. As I say, some parts of the country have been working to this sort of model for some years, although it is only really now, as we move towards providers working in collaboratives with joint control totals, moving towards system control totals, system performance, for example, in terms of the phase 3 ask, that the importance now of providers working collaboratively is more clear than ever. The groups that in a formal way we've established much more quickly than others, because we've needed to in relation to the recovery programme, is in relation to the clinical strategy and ops group. And at the moment that is very much focused on our elective recovery in, of course, patients, non-COVID patients, diagnostics, critical care, and diagnostics including imaging, radiology and endoscopy. The chief executive group also in a sense has dual accountability. So on the one hand, we've established a committee in common, top left, APC CIC committee in common, which is proposed to meet quarterly, and that is what it says. It's actually at the moment set as an advisory rather than a decision-making committee in common, with representatives from all three trusts, and we have another committee in common, I think it is next week. And certainly the first one we had a couple of months or so ago was extremely positive, and I think does bode very well in terms of collaborative working. But of course, in many respects, John and I were talking the other day, the whole point of having an integrated care system is that we are integrated and we don't just carry on providing care in the same old-fashioned way, with the acutes providing their own care in their own little bubble and so on. So we are a fundamental part of the South East London integrated care system, and I, as the SRO of the Chief Executive Group, represent the acute collaborative on that group that is currently chaired by Richard Douglas. And so there is significant overlap in what we're doing. It's important the system is clearly aware of what we're doing, and on many occasions it's important that we are an absolute fundamental and integral part of the all elements of the integrated care system. So if we just go on to the next slide, please. So I mentioned some of its early priorities. Now ultimately, the plan will be that really all our activities across the 3 acutes will be coordinated by the acute provider collaborative. So that doesn't mean that we'll be a merged entity. It doesn't mean that 2 or more of the trusts necessarily will merge at all. It's quite possible and has been demonstrated to be the case elsewhere where we can run these as a true partnership, a true collaborative. However, because of where we are in relation to the pandemic, we are concentrating our efforts at the moment in relation to the restart of our elective care, and where we can, our transformation alongside that, and the specialties are as listed up there on the top left. There are those 6 specialties grouped from orthopaedics down to general surgery, which is the widespread ask from the London region, and London has been, to be fair, ahead of the curve nationally in terms of trying to get formal elective programmes in this way restarted. We have an additional area of clinical concern in South East London because of the fact we've got 2 very large dental hospitals, one at Guy's, one at King's, and so we've got specific issues with patients waiting for dental treatment and outpatients. And so we're adding that as a 7th. We're also concentrating, as you can see, on the diagnostic element, and I won't repeat what's on the slides, and also making sure that we, and we did this actually, to be fair, early on, pretty much throughout the pandemic and ongoing, in making sure that we were well prepared in having enough critical care facilities to care for patients with COVID-19. And now subsequently, we've got really pretty robust plans in place to ensure we can care for patients who require critical care with COVID-19, and as far as we possibly can, notwithstanding any workforce issues and shortages, make sure that we can maintain critical care services for our elective and, of course, acute non-COVID patients on this occasion. So there's really quite strong plans across the 3 acute providers in that regard. Just to go on to the next slide, please. So as I said, I think at the beginning, I think it is important to stress that there is actually quite a lot of good work that's been done down here in South East London in relation to collaborative working, and urology is a very good example. And there has been a network established now. Some of the so urology network, I believe, was mandated by the centre a couple of years ago, and not everywhere has necessarily come as far as South East London ICS, but nonetheless, you can see that in certain parts, Guy's and across the Lewisham and Greenwich and Guy's, for example, joint consultants are in place. There's a well-established network. Ben Travis, the CEO of Lewisham and Greenwich, is the SRO and chairs the meetings, and there's lots of challenges, but I know the last 18 months certainly that I've been here, Ben's done a terrific job in developing those collaborative ways of working across this patch. And so there are clearly some basic principles that you can see, bottom left, key principles, equity of access, no need for long waits, etc., which what we're saying is that is a South East London issue. So it's not acceptable for one part of the patch to have very short waits for any particular condition, urological, and another part of South East London to have very long waits. So though these sort of principles really are those that we would expect to see now across all services as we roll out this networked way of working across the collaboratives. And you can see in terms of the progress to date, some of the benefits that have come out of this way of working. You can see in terms of some of the immediate priorities, in terms of increasing the number of high volume, low complexity procedures. So about moving them out of the big teaching sites, moving them to Lewisham and to the Prue, and Guy's and Thomas's will continue to remain as the site where the very complex urological work for the whole of South East London is done. So that's really just a case study of what it could be like and what it should be like, and what we hope it will be like for pretty much all of our services over time. If you just go to the next slide, please. Again, there's a similar case study here, and of course you've got the material, so I won't go through this all now really, but again, it's the same principle that individual trusts, and we've all been encouraged to work in competition with each other over the years. We've been encouraged to basically look after ourselves and our own patients. And this is now very much establishing a mindset whereby we work collaboratively so that we can provide equity of service across the South East London area, and that we maximise all opportunities we possibly can to provide safe care as productively and as efficiently as we can. Now, there's lots of challenges around some of this. So, you know, there's the issue, of course, of the workforce, be that is there sufficient workforce, be that you know, quite large sections of the workforce are very used to the idea of only working for their own organisation, and of course employed only by their own organisation. So it is about how we break down those barriers. There are challenges around whether patients are prepared in any way to travel from one area, from one organisation to another for treatment, and there are lots and lots of issues, to be fair, but there's another issue which is fundamental, which is that basically not only do we need to provide equity of access, but we need to provide equity in terms of the standard of care delivered. So there is no real justification. I'm an ex-radiologist, so I know a little bit about clinical care, but not very much. So there's no real indication, to be fair, I don't think, for relatively straightforward procedures to receive different types of care in different hospitals, in different departments, and even within the same department. So we really got to minimise unwarranted variation. We all know we've had to do that in our own practice, we have to do it in our own departments, and I think now the emphasis should be on minimising that unwarranted variation across, in our case, South East London. So these are all issues, even without COVID, that we should be working towards, and I would hope even without the COVID pandemic I'd be able to present to you in this way today, that this is what we're working to as a collaborative. But now, in the presence of COVID, this is kind of more important than ever, because we clearly have to have separate pathways for patients who are known or suspected COVID and those who are who do not have COVID, and it's important that we don't cross-contaminate, and it's important we don't infect non-COVID patients. And so there's a real need for us to maximise our services and our facilities across the whole of South East London, and we can only do that if we work together, in this case in relation to the three acute providers. And so my final slide, please. So I think, what are the next steps? So we absolutely can only succeed in working together as three acute providers if, as I say, we standardise our approach to referrals, to diagnostics, to assessments, to treatments, to follow-up, and so on and so forth. And that is what we're working towards. We're working towards making sure we've got clinical leads or clinical directors of each of the services across South East London. And we're looking now, we discussed today the notion of having some form of medical or / clinical director for the whole of the acute provider collaborative, so that we can, as I say, start to work in that way, in that horizontal way. The one thing I think that is very important, that I think we probably can do better than most places, is also make sure we work what I would say in a vertical direction as well. So a lot of acute provider collaboratives nationally have been set up just to deal with that horizontal layer, if you will, and of just how the acutes work together. I think because of the work Jonty and others have done down here, I think there's a real potential for us to make sure, not just, for example, that the three acute providers maximise their outpatient productivity, that there's no outpatient space available in one hospital while patients are waiting long periods for outpatients in another hospital in South East London. What we also need to do is work vertically with primary care and all providers, all stakeholders, to make sure that, for example, do we actually need to provide outpatient services in the same way we used to? Do we need to completely revise the way we manage our follow-ups? Can we do it in primary care? Can we do it with nurse swaps? Do we need to do it at all? And that really can and only should be done on a system-wide basis. And so I know that Johnson and I are really think very similarly on this, and so it's a very important thing that we make sure we join up all elements of the provision of our care, both horizontally and vertically. Hence the, as I say, the integration word in the ICS. We need to move towards the three trusts, trusting each other, being open with each other, sharing problems, speaking with a single voice from South East London, particularly at London, and potentially even national level, so that we can get the very best for our staff and for our patients. I think I've talked about the importance of standardising our pathways, hopefully sharing our waiting lists. Is a possibility, particularly at a time when our waiting lists are now so long and we've got so many patients waiting, particularly because of the impact of COVID. But fundamentally, and if COVID has taught us anything, it's taught us that health inequality is absolutely real, and is certainly real in this part of the country, that everything we do, we must make sure we are creating or minimising health inequalities. Although finally our focus for the next probably 6 to 12 months or so, I guess, really is going to be about trying to recover from recover our situation in relation to the pandemic. And this is not, in my view at least, and I'm sure I speak for Ian and Ben and the three trusts, really, this is not a short-term fix. The future is collaboration. And as I say, that collaboration is not just horizontal, but it's vertical, and it's also with our other provider partners, be they Bromley Healthcare or SLAM or Oxford and so on and so forth. So I have to say, although this is hard work, I think had I had a choice about working with colleagues to establishing an APC, a collaborative, would I have chosen to do it just towards the end of a once-in-a-century pandemic? Probably not, but I think it has certainly encouraged us all to realise how important it is. And I think, honestly, Jonty and Andrew have been terrific supporters of this, and I think this bodes very well for South East London. So I've pretty much kept to time, Jonty. I'm happy to take any comments or questions.
Thanks, Clive. Fantastic. Yes, I think we, as ever, are quite ambitious in our agendas, and so time is relatively tight. But there are a number of people who want to ask some questions. What I think I'm going to do is try to, if you're happy for me to do it, is to get people to ask a number of different questions first, and then come back to you perhaps to answer them all at once rather than doing them one at a time. Yeah. Is that okay if you got it? So and I suppose just I wanted to take Chair's prerogative and just ask one from myself as well, which is specifically around the role of RQ Trust, because you're such massive sort of institutions within South East London. We talk a lot about anchor institutions, and I suppose I wondered what thought there had been between the Acute Provider Collaborative in terms of what is the role or of the Acute Provider Collaborative in relation to sort of local communities and employment and as anchor institutions. I'd just be interested in reflections if you have some on that. I then wanted to bring in Simon Parton, and if you could just introduce yourself and your role. This is for governing body members, that would be great. And then I'm just going to bring in a couple more people as well. So Simon, yeah.
Thanks, Jonty, and thank you, Clive, for a really interesting presentation. I know time is tight, so I'll be very quick. Two questions essentially in one. You referenced integrated systems and horizontal working. I think that as we move into ICSs, if we're going to get things connected, we need to ensure engagement across healthcare partners at inception of design, if you like, and inception of planning. So I just wondered what engagement has thus far happened with primary care, and what are the planned intent in terms of engagement. I would suggest that with the significant amount of work you're doing and the really impressive direction that you're taking things, I would suggest early engagement results in a better outcome, and rather than trying to reinvent things later. Thank you, Jonty.
Thanks, Simon. I should say, so Simon is the lead for the LMC in South East London, right?
I apologise, John, you had asked me, and I forgot. I'm Simon Parton, GP in Lewisham and LMC rep for the governing body. I apologise.
No, not at all. That's great. Thank you very much. And just while we're capturing some particular questions, I wanted to just go to Neil. Neil, did you want to come in with your question?
Yeah, thanks very much. My question is just about the role of King's Health Partners in supporting the Acute Provider Collaborative and the opportunities, particularly thinking about Lewisham and Greenwich Trust, which has been probably more on the periphery of King's Health Partners to date, and how that might be able to be strengthened and supported through the role of the APC.
Thanks, Neil. I just wanted then to go. There's a few people who want to ask questions. So, Falake, can I get you to ask your question? I might then just pause and let Clive come in.
Yes, thank you, John T. My name is Falake Shegun. I'm the Director of South East London Health Watch, here representing the patient, a public voice on the governing body. Thank you very much, Clive. As you start to improve the visibility of the waiting lists with each other on the APC, will this information be shared with patients when they are booked, when they're booking into services, or indeed with patients whose treatments has been delayed as a result of COVID? And will this increase patient choice as well as a result? Thank you.
So, Clive, are you happy to pick up on those, and then there may be one or two more? But are you happy to?
Yeah. So I realise time is tight, so I'm going to kind of give one or two sentence answers, John T, if that's okay. But I'm very happy to speak to anyone, as John T will know, outside this at any time on one-to-one. So I think the question, John T, around anchor institutions. So this, the fact that we are here permanently, King's, GST, St Lewisham and Greenwich, you are absolutely right. We are anchor institutions. We are very significant and should be very significant influences on the, in terms of the health and social well-being of the populations we serve. I can't speak for the other two trusts. Of course, I can only speak for King's. I'm not sure we're quite as far down that delivering our responsibilities at King's as an anchor institution as we should be. So I think this, having the three of us together in this way will help us. I think in many respects the ICS is also probably the biggest anchor institution anyway. So I think there's certainly a lot more work to be done. There's quite a bit of work that GST and King's are doing as part of the Shelfer Group in relation to anchor institutions, but I would like us to see us do a lot more. I would like to see King's itself, at least, and I have said since I've been here, do a lot more out in the community, influencing the health and well-being in a way that we should be doing, and perhaps others are doing better. I think in terms of Simon's point, so you're absolutely right, and John and I were speaking about this only the other day. So first of all, I apologise. That we set this group up really rapidly. I mean, just as an example, we kind of almost set this up in the collaborative in a matter of weeks. I think in West Yorkshire, it kind of took us about a year. I think Manchester took a bit longer. And we in many respects had no choice. The situation had deteriorated because of COVID, and the support we need to provide each other during COVID was such that we had to establish this. But Simon, you are right. Although I showed you that, organogram and so forth, it is only, as most things are in life, temporary. We'll iterate this as we go along. We're certainly going to look very carefully and are looking at the South West London model, where there's kind of joint leads for primary care and second care for each service, because I'm a very strong believer that the old model of the old-fashioned way, that whatever's in the hospital stays in the hospital, those days have gone. So we definitely need to engage with all elements of the ICS. I totally agree, and that includes patients. I know I've just noted some of the questions. It includes Health Watch and so on. But we are a very new group. We don't have much in the way of resource for the PMO. That's not to say I want you to all feel sorry for the likes of King's and Guy's St Thomas's with rather large turnovers, but we just, of course, got to get the structure and the support in place, and we will engage as widely as we possibly can. So the problem with being a doctor is I can't actually read my handwriting. So Neil, of KHP, I think. So Neil, you asked about KHP. Yeah, so we have talked to KHP, to Robert Leckler, to Jill Lockett about this, and I know Jill and Robert have spoken to Ben Travis and to Val Davison, their chair, early on about this. And so we are, so I think we could make this work if KHP only included Guy's, St Thomas's and King's and not Lewisham and Greenwich, but it will be much, much better if somehow we were all part of this together. So I don't want to preempt anything. We're not the only members of KHP. We've also got, of course, KCL and the University and SLAM in there. But I think there's a general mood music towards KHP becoming more inclusive than less. And so I think that will help in many respects us move forward on the collaborative, three-way collaborative agenda, not just in terms of provision of acute care, but in terms of the public health, the population health agenda, for example, that's in place across the ICS. So I think, Neil, that's a key point, and we are working on that. And then Faloki's point about the Health Watch. So yes, so I think this is a tricky one, to be fair. I think we do have to make sure we communicate more widely, certainly better than we have been doing. Patients need to understand that these are really quite different times, that we have developed very long waiting lists. I know King's has had long waiting lists for some years, but across South East London now we've got very long waiting lists, and we need to take some collaborative action to get our patients, to get you as the patient treated as quickly as possible. And if that's only a temporary arrangement whereby we're asking you to be treated somewhere else, we need to let you know. And ultimately, of course, the patient has a choice. But I think we do need to improve our messaging and communication about all this. I agree. I think that's it.
Thanks, Clive. Yeah, and I guess one of the other aspect, I think, Falake, of your question was around patient choice in this, and I think in some ways that's a kind of whole system responsibility to be thinking about the communication that Clive is describing. A lot of the conversations that we've been having with patients across and members of the public across London have indicated that people are very willing to forego choice with the right measures in place to ensure that it doesn't create further inequality, for example, and doesn't disadvantage people in terms of having to travel further. But they are definitely happy to compromise, particularly where that enables them to access care safely. And that's the key challenge that I think Clive was talking about, was how we ensure that people are able to access care safely, recognising some of the challenges that are around estates and being able to sort of separate out those pathways in the way that he described it. But I wonder whether that's something we should be collectively taking on, is how we think about communicating. We're talking about patient engagement later on the agenda, but I think there's something at the moment about collectively how we do that and how we do it through practices as well, because of course most people before they go to hospital will have spoken to a clinician in the community, and so I think there's an opportunity there also for us to think about how we get the message out on this. So I think that should be a collective responsibility, and I think it's important we understand people's willingness to kind of compromise on choice, and I think that is going to be important over the coming months, particularly if we're going to try to continue to do all of the elective work that's happening at the moment, alongside responding to any further surge that there is in COVID. There was one further question, I think, Clive, from Nancy. Nancy, did you want to come in?
Yep. Hi, thanks, Jonathan. I'm Nancy Cusherman. I'm a GP and I represent Southwark on the governing body, and my portfolio is mental health. But what inspired me was your case study about urology, and it reminded me of some quality work we did relating to that, and I wanted to share that with you and ask a bit about how to then link that up with the provider collaborative. So we did had a meeting about a year ago, probably, about catheter care, and identified that a lot of people leaving hospital with catheters didn't have catheter passports, so follow-up wasn't clear, leading to a lot of variation in practice and outcomes. And it just got me thinking, I suppose, you know, good care would be consistency in terms of catheter products, you know, minimising waste, clear follow-up, clear documentation, but also the opportunity to share skills across primary care, secondary care. So one of the things we've talked a bit about before is rotating nurses from secondary care into the community to support pathways like catheter care. So I just be interested to hear how you might participate in that kind of transformation as a collaborative, because one of the things we did was we focused this in Southwark, and we were relating to the community teams from Guy's and St Thomas's, but clearly this South East London is much bigger. You know, we've got that tension between PCNs, which are quite small, primary care networks and neighbourhoods, and then we've also got this huge footprint. So how do we maximise this to make the most of the scale that the collaborative is offering?
Sure. So I think, as Andrew, I think is on the call, will know, before my interim appointment here, I did demonstrate how committed I am to the integration agenda. So West Yorkshire and Harrogate was one of the largest ICSs, second wave, 2.7 million. But our main principle was about subsidiarity. You know, that was our driving principle. Of subsidiarity was the default position in terms of delivery of care. So when I describe, as I did just now, the APC, the Acute Provider Collaborative, and talk to other people, I know and I can see and hear them thinking quite rightly, this is just the acutes getting even bigger and even more powerful, and, you know, floating off into the distance. And some of you might remember Simon Stevens' initial 5-year forward view from about whatever it was, 6 or 7 years ago, where there was all the 3 or 4 different options, and one of those options included the acutes kind of floating off together somehow, which I never personally really agreed with or understood. I get that could be a concept, but that didn't seem to me to be how we provide integrated care. So I think what we have to do is to get the acutes going. I think we need to be really careful that we don't become so dominated by other agendas outside of South East London that we only concentrate on doing more of what we've historically done, just harder and faster, and that we stop and realise that the only way we're actually going to provide better, more joined up care within a fixed funding pot is to do it in an integrated way, in the way, for example, you've described. But the basic premise of that is that we have to standardise all elements of care, and that we have to clearly describe how all elements of care across all the sectors are joined up. And, you know, we've all experienced it. You know, my father-in-law up in North Yorkshire had a pretty grim death in relation to dementia. So each element of the care he received, whether it, you know, was in hospital or in social care or so, was fine, but it was so poorly joined up that the totality was a disaster. And I think most of us are pretty good at providing bits of care in its silo, but in terms of doing it in a joined up and standardised way, that's what we've got to aim for. So your example is absolutely right.
Thank you very much. And I think kind of what that completely demonstrates, Clive, is why we're incredibly lucky to have you in South East London. And I think, but it's sort of important. So I mean, I guess I just wanted to finish by saying thank you. I mean, yes, to you personally, because I think your leadership here has been fantastic, and I think the experience that you bring with you is incredibly helpful as we kind of undertake this journey towards an integrated care system, and to have some of the insights that you offer is important. But also, I guess, just on behalf of the governing body, I wanted to ensure that we were thanking all of the staff at King's who've been working so incredibly hard over the period of the pandemic, and are continuing to do so to try to get services back up and running. I think we have continually reflected on the incredible work that people are doing on the front line of the NHS, and so it's just important that I call that out, and thank you for your time today, because I know how precious that is. So very much.
Thank you for asking me. Nice to meet you all. Thank you.
Not at all. Take care. Thanks, Clive. So we'll move on now to the next item on the agenda. People will be aware that we try always just to include a reflection, an opportunity to look at a showcase, something that we've been doing in South East London that we feel demonstrates really good practice that can be shared. And what we were going to do today was to look at a video that has been developed in Southwark to encourage people to have immunisation, and I think we'll go to the video first, and then we may just have a comment from Angela Barn, just in terms of giving us a bit of the context around childhood immunisation. But I think this was a really great initiative to try to encourage people to to continue to get children immunised during the pandemic. So wanted to share it with you. Simon, are you able to play that now?
We know that keeping your family safe is your top priority.
And it is ours too. That is why we are continuing to offer childhood immunization services at your GP practice and through our extended primary care service.
Missing immunizations can put your child's health at risk from diseases that are far more contagious and life-threatening than coronavirus, especially now as the lockdown rules start to relax. Delaying immunization boosters can lead to lower immune protection for your child and the possible need for further immunizations to boost their immunity in the future.
We have taken every precaution to ensure that when your child comes in for immunization, they are seen in a clean, safe, well-spaced environment by one of our practice nurses with a full and adequate protective equipment.
If you have any questions about immunizations or your child's specific needs, please contact your GP surgery to speak to a clinician who will be happy to help. We are looking forward to seeing you soon and helping keep your children safe and healthy.
Thank you for listening. Bye.
Thank you very much, Simon, for playing that. I wanted to share it because I think, again, it's an example. There are many examples of real innovation that have been happening to think about communicating with patients during the pandemic. But I guess, Angela, it does prompt the question about how we're doing in relation to childhood immunisation and why it felt necessary to develop that video. Did you want to say a word or two about that?
Yes, thank you, John. It was great video. And you know, the good thing that we should be doing as a new CCGs, sharing good practice from one area to another. So that would be certainly something we should be sharing. So, as mentioned in the video, during the pandemic, the uptake of childhood vaccination has fallen, not only in South East London, but across London and across the country. Now, more recently, those levels have returned to normal or near normal, but actually we know that there are huge inequalities in health in relation to immunisation. So in some areas, we are seeing quite low levels of uptake of childhood immunisations and a reduction in protection for those children. So we are working together in South East London, not only for flu vaccination, as we talk about so much, but also to try and improve vaccine levels in children. So we want to not only return to normal, but actually improve, and also try and ensure that we've identified and offered immunisation to those children who may have missed out during the peak of the pandemic. The things that we're focusing on locally are supporting practices to ensure that there are good systems of call and recall, that we're communicating well, and this is a great example of how we are starting to do that communication, and also the infection control arrangements in this at this particular time, because parents will want to know that they are not at risk of catching any viruses, and their children are not at risk as well. So this has been an area of focus for London as a whole, and also South East London. So we will continue to work on these areas. I just want to talk about one or two things that have been happening over the summer. So because the schools programme had got so far behind, all of the boroughs, all of the borough teams have been working with the schools immunisation service to ensure that we can provide those schools immunisation over the summer at a level at places where outside of schools. So we have in fact caught up with our schools programmes. We've also been very impressed by the initiatives such as this and elsewhere in London. So some practices have been giving vaccinations in car parks where people feel it's important to to not come into the practice. So we will continue with this work, particularly alongside the flu immunisation programme, and we will also get a renewed focus on it after the winter months.
Thank you, Angela. Really helpful just to have a bit of context to that, and many thanks to the federations in Southwark who developed that video. We'll continue to share some of these examples of great practice as we go on. We now will move into slightly more detail on the pandemic response, and ensure that we update the governing body on a number of elements of the response, our planning processes, and current public health challenges. I think I just wanted to remind presenters about the time, because it's a relatively tight agenda today. But on that note, I'm going to hand over to Christina first, and then we'll get Annabelle and Nada to come in after that.
Thanks so much, Jonty. And yes, I will go through this relatively quickly. Hopefully people have had a chance to have a look. And also the first part, before I hand to Annabelle to talk about recovery, largely touches on some of the statistics, which I know Nada will touch on as well. The only thing that I wanted to draw out, as well as the fact that you'll see from one of the graphs that we've included here, that our rates of infection are fluctuating, but are showing a general incline, which is consistent with other parts of London and in fact the country, and is something that we are monitoring closely. Also, in terms of our numbers of cases and deaths, as per the slide that's being shown at the moment, this is obviously our cumulative total, and whilst of course really concerning to have any more cases and certainly any more deaths, it does show how the severity of COVID that we have been experiencing over the last couple of months has significantly slowed, with 32 deaths in the last 2 months. And considering the pandemic has really kind of been going for the last 6, and in total we've had over 1,600 deaths across South East London, it's really proportionally much slower, which is positive news, although of course something that we are tracking very closely. If we could move on, please, Simon, to the continued focus on response and resilience slide. Just wanted to talk about some of the measures that we've had in place ongoing. Whilst the trend has been downwards for a good period of time up until recently, we have maintained, as Andrew had mentioned, for those of you who joined our AGM, we've maintained a strong surveillance with Gold meeting every single working day to ensure that any actions that do need to be taken are done so promptly, and to monitor really closely some of the indicators, which I'll come on to. We continue to work really closely with other partners across the ICS. We have invited members of the local authority, both adult social services and also public health, to join us at some of our Gold meetings to share intelligence and also to participate in some of the discussions. And likewise, we work with them and attend some of their meetings, and continue as well to discuss across the acutes and other providers at least once a week about the current status. And then another thing that I think is really important principle for how we've been responding to this pandemic right the way through, which is it's not about what the CCG needs to do, it's about what the CCG can do to contribute to the system overall. We've prided ourselves on going beyond organisational boundaries and wherever possible beyond the scope of what's asked of us as a statutory CCG organisation to support our partners and to support the health and care of all of our residents across South East London. And then just the next slide, please. In terms of looking forward, as I said, whilst over the last couple of months we have seen some declines in the activity here, largely related, of course, to lockdown and the measures that have been put in place there, it's really important that we are prepared and ready for increases, and we are starting to see cases rise, and we need to make sure that we're ready for the risk of a potential second wave. We've conducted an after action review, both within the CCG and all of the things that we monitor, and also we've discussed with our other ICS colleagues as well about what we can learn from the way that we managed those previous incidents and what we can do better in the future. That's been enhanced by an exercise that we've run recently, and also participated in other exercises where essentially we use theoretical situations of declining performance or increasing concern to discuss how we might address that. And that gives us an opportunity to kind of play through some of the decision-making processes, some of the ways that we communicate, and identify any issues that we need to rectify ahead of the future. I mentioned as well that we are monitoring the situation closely, and as part of our daily activity and discussion at Gold, we look at a number of early warning indicators with the hope that this will tell us the information that we need in order to take early action if things are getting worse. This includes how many cases we've got and the prevalence across South East London, the number of calls to 111, as obviously this is an indicator of people's both concern and where there are symptoms, admissions for COVID-19 and beds occupied. This forms part of, as I say, of our discussion every day. We invite other colleagues to join us if there are areas of concern, and make sure that we follow up with anything that tells us that we need to take action. So between these learnings and the monitoring, that's the way that we can ensure that we are as ready as possible to deal with any further areas of concern over and above the sort of monitoring that we've been doing up until now. I'm going to hand over now, if that's okay, to talk for Annabelle to talk a bit about recovery.
Perfect. Thanks very much, Christina. And for those of you who don't know me, my name's Annabelle Appleby, and I'm the Director of Commissioning Strategy and Acute Based Care within the Planning and Commissioning Directorate for the CCG. So Simon, if we're able to scroll down to the first slide, thank you. So today I just wanted to give an overview of the recovery planning process that we're going through as a CCG at the moment. I won't go through all of the slides in the pack given time. Hopefully people have had a chance to have a quick look through in advance, but there are a couple of key points I just wanted to draw people's attention to. So the first is we have set out overall recovery planning objectives which we are working to, which are set out on this first slide, and these are around addressing the public health burden, understanding and addressing inequalities both within and across the boroughs in South East London, and both of those we know have been impacted and exacerbated by the recent COVID pandemic. We're focusing on a safe return to service delivery in every care setting, looking at how we can capitalise and lock in on new ways of working, and importantly, how we can live within our means and optimise the utilisation of resources that are available to us and to our partners. In order to achieve these objectives, we're taking a blended approach to our recovery planning, which balances planning at a local borough level and also at a South East London level. So taking into account both local priorities and making sure that we're responding to national and regional requirements. The foundation, therefore, of our planning process is borough recovery plans. Simon, if you're able to scroll to the next slide, that will give people a bit more information on this. So the borough recovery plans, this slide sets out at a high level what these plans have focused on, and that's mainly around understanding the impact of COVID within the borough, the local plans and priorities at that level of our geography, and enabler support. By that we mean agreed actions to secure required infrastructure to support delivery plans. So each of the boroughs in South East London have been producing borough recovery plans over the last 2 months. That development process completed at the end of August, and those local plans are being discussed at borough boards and health and wellbeing boards during September. So these plans are really providing a place context and providing the foundation for our South East London recovery planning process. If you can scroll to the next slide, Simon. What we're then combining with those borough recovery plans is the phase 3 national planning process, which is going on at the moment, and this is predominantly being done at a South East London level. So we received the phase 3 planning guidance in August, and what it does is set out a number of delivery expectations for the rest of 2021, and they're mainly focused around the recovery of activity and how we can restart services safely that had to be temporarily paused during the COVID pandemic. We'll be continuing to work with our system partners to ensure that we have robust and credible set of plans, and the final submission is due on the 21st of September. These plans will provide the underpinning activity, performance and workforce detail that support the delivery of acute recovery and mental health performance targets. If I'll come to the point at the bottom of this later, which is I guess how this all comes together in our medium term planning. So that phase 3 national planning process focuses on the rest of this year, and there is an expectation that we will receive some phase 4 planning guidance later this year, which will set out the requirements for 2021. So what we will be doing as a CCG is pulling together the plans that we have at borough level and the recovery plans that we've put in place so far during our phase 2 and phase 3 national responses, and we'll be building on that throughout our wider 2021 planning process. And I won't go through it in detail due to time, but the proposed process for our 2021-22 planning process is set out on the following slides in this pack. I don't know if you want to take the next item as well, John T, and then come for any questions.
Yeah, I was going to say perhaps we'll just move straight on to Nada if Nada is prepared and ready to go. I think it's quite good just to flow through all 3 of these items and then we'll come to questions. Nada, are you with us?
Yes, thank you, Jonathan. Thank you very much. Hello, good afternoon. I'm Nada Lemick. I'm a Director of Public Health in Bromley, but representing here at the Public Health Department across South East London. I'll just briefly go through some of the slides because Christina has already mentioned some of this, this information. May I have the next slide, please? So just briefly about the epidemiology, this just shows a cumulative number of cases that we had in South East London. The red bars are our boroughs compared to other London boroughs. Next slide, please. And this is the rate per 100,000. Again, this shows how our boroughs compare with other London boroughs. Next slide, please. Now, this is what Christina was saying. We do monitor. There are certain indicators that we regularly monitor to be prepared when the things go slightly wrong. Now, unfortunately, this is data from the last week, and things have unfortunately gone in the wrong direction since last week. 7-day confirmed laboratory case rate is something that we monitor continuously. Unfortunately, since last week, our figures have gone up. So particularly Lambeth and Southwark. Lambeth is now at 29.5 per 100,000 and Southwark at 24.3 per 100,000. So they are now in the amber region. This means that they are under, if they call it, under national concern and potential support. Next slide, please. Individual positivity for individual boroughs. Again, this has gone slightly, but slightly up, not so much, and we are still in green. We are just around 2% still, which is a good sign that our positivity rate is not going up. So at least that is a relatively good sign. Next slide, please. Now this is a slide that actually pulls together some of this information. As Christina earlier said, we are all doing a lot of surveillance, and these are the indicators that both us and Public Health England is watching and considering when looking at particular areas. As I said, this is unfortunately, as I said, slightly out of date from last week. Our incidence rates have gone up, but our positivity rate has stayed relatively stable, so it's still green, which is a good sign. Next slide, please. Yes, and I just wanted to say something now about our joint work. And before I do that, just to say about COVID, what we are seeing generally in South East London, and we had a lot of discussions now because once a week we now have joint incident management team with Public Health England. So 6 directors of Public Health. Public Health England, and Christina and Kate has joined us as well from today. So we have this from yesterday, sorry. So we are having these joint meetings once a week. Now, what we are actually seeing in terms of COVID, and that is, it is obviously concerning that we have continuous community spread. We haven't been seeing so far specific outbreaks in specific settings, and odd small outbreaks and clusters, but nothing major. So there is a general community transmission and increase in cases in South East London and London. So that is quite a picture that we're seeing in London, not something that has been seen, let's say, further north or in other areas. So what we are doing, as I said, this is this particular group that we've just set up, the South East London Incident Management Team, which is, I think, a really important joint group, and we have colleagues from the CCG as well. We do have a lot of joint work. Particular one is on how we support each other and work jointly across, because our teams are fairly small, and building some resilience into the system is important. In terms of changes to what we do, particularly important one is changes, and you probably heard about it, about contact tracing, because there has been problems with contact tracing. The results haven't been very good. And Public Health England is now, some areas are starting to do a joint contact tracing with Public Health England. In South East London, Southwark is a borough who is the first one. They started today actually, but other boroughs have also expressed interest. So we are moving towards the situation, and we are going to do joint contact tracing with Public Health England. We are also doing much more work on individual settings, like schools in particular, and Public Health England I think their capacity is now being really tested, especially with schools starting. So we are taking quite a lot of work, especially with schools and single cases in schools and care homes that in the past were done by Public Health England. So one of the issues for us is capacity. Joint working is therefore very important, that we can support each other, have some mutual aid, and develop some systems to how can this work across South East London. Thank you. I'll stop here.
Thanks, Nada. So I'm just going to turn to members of the governing body for any questions that they've got for any of our speakers. Joy, I think you wanted to come in.
Yes, thank you, John T. My name's Joy Ellery. I'm a lay member for the CCG, and I lead on patient and public involvement. We've heard a lot in the media about how long it's taken to get results for COVID tests. And I'm particularly worried about our NHS and social care staff, because workforce is just so crucially important to delivering our services, and also for the public, so that they can get back to their work and to their normal lives. So I wonder if we got any information. The national media seems to be giving out median times, and I'd quite like to know something a little bit more exact than that, maybe. Thank you.
Do you want me to come into that on that?
Yeah, why don't I should have said Christina, why don't you come in, because I know you are looking at all things testing. So
yeah, so in terms of result times, I don't think, unless colleagues correct me, there's been a substantial change actually in that. It's usually around sort of 48 hours, give or take, for some of those tests. Although, of course, there was a challenge with it earlier in the year, but it should be around that. The biggest problem that we're facing at the moment is actually getting the tests at all, and there's a lot in the media going on about that. So the testing that at the moment, both symptomatic health and care staff, but also members of the public access, is the nationally provided, it's called Pillar 2 tests. And because, although they've increased capacity, because there's been outbreaks and hotspots in particular places, the capacity has had to be diverted there, which has meant availability for people in other places has been really challenged. Something that we're monitoring really closely, and also discussions have started about how we might be able to stand up potentially some local provision. Unfortunately, because of the capacity constraints that exist within the NHS provision as well, anything that we would do would be contributing mostly to the sort of health and care staff side of things, people who needing to test, but absolutely recognise there are continued problems for the public as well. And as I say, it's something that we're kind of monitoring and working on very closely. I hope that helps.
It does, thank you, Christina. One of the things, Angela, just while other governing body members are thinking about any questions they may have. I just wanted to, we touched on this I think at the last meeting, but just ask about flu. So we know that this is a high priority, and I suppose it's just to get your sense of our sort of preparedness, if you like, for the flu season, in terms of practices, being able to vaccinate the patients, but also in terms of staff, because we know it's incredibly important that staff are vaccinated. So I just wondered whether you've any update on that.
Yes, certainly. So South East London has developed a very strong network on flu vaccination. So each of the borough leads and indeed the borough-based directors are attending as part of a network, a fortnightly meeting, and there are a group of us working at South East London level to try and ensure that we have robust plans and processes in place. So we've done the usual things that you would expect, which is communicating with practices. We have a special flu bulletin that goes out regularly in addition to the normal GP bulletin from South East London, where we give advice and information about resources and communications. We are expecting a big communications campaign to start nationally towards the end of this month, because as I said earlier in the question, the actual flu vaccination season starts at the beginning of October. We are keeping a close eye on supplies of flu vaccine, and we have talked to all practices about their supplies and their ordering, and to ensure they've ordered enough. We expect to get more stocks through the flu season as we go forward. We're also working with all of our lead providers on ensuring that staff are vaccinated, and all of the main providers in South East London have furnished us with their flu plans, and we've just completed an audit of all those flu plans and are in the process of going back to organisations with those. So we are expecting those. There's 100% target to get healthcare workers vaccinated against flu. The other targets for the over 65s is 75%, and those at risk under 65 is also 75%. We are expecting to, of course, vaccinate 50 to 64-year-olds later on in the season, though not yet. We haven't had formal notification about this at the moment. And the other group of people that we are particularly concerned about is those who are residents of care homes, and we are talking to our boroughs about ensuring that there are robust systems in place to vaccinate not only those residents but also staff of those care homes, because what we don't want to do is to have co-infection with COVID-19 and flu. I mean, there's so much more that we have done. We're looking at the potential for mass vaccination centres. We're sharing good practice, such as one of our team has developed a protocol for sharing vaccine between practices. We're looking at areas of traditionally low uptake for flu, and seeing if there's some targeted campaigns that we can do around those populations. I can actually come back at the next governing body if it's helpful to say what we have been doing and how it's going, because that will be in November, where we'll have got a long way through.
I think that would be very helpful. Thank you, Angela, because I think it's something that we should be keeping a close eye on as a governing body, and that would be really helpful. We're keeping a close eye on, and there's many of us who ought to be making sure that we're vaccinated. So perhaps we'll also have a little internal audit, just to put people on the spot. OK, thank you very much for that. There's just another quick follow-up, I think, on the testing from Mary.
Thank you, Jonty. Yeah, I just wanted to ask about how we're specifically supporting healthcare staff to access tests in South East London. And particular reason for asking is I heard of an example earlier this week where staff were able to get support from the occupational health departments with in their organisations to help them get appointments quickly rather than just sitting in a queue on their sort of laptops, for example. So it'd be good to know that we were doing something in South East London that specifically focuses on those individuals to ensure we can ensure continuity of care for patients through the winter.
Thanks, Mary. Christina.
Yeah, so in terms of the occupational health link, there's not a formal process by which that expedites access to Pillar 2 testing. I understand that there are some potentially additional providers who are connected through occupational health providers and have been accessing in that way. It's not an arrangement that we've got in South East London. It could potentially be something that we look into, but our first priority, as you say, is to make sure that we have some additional provision for health and care staff. And so we've actually been talking just directly with our local labs and providers about how quickly they could stand up local arrangements, and then we would manage through the testing team, we would manage input in that way. So if that isn't able to be stood up in time, occupational health might be something that we look into, but at the moment it would probably be an additional step, and we're hoping that we could do something a little bit more expedient.
Thanks, Christina. Again, I'd reiterate what Andrew said in the Andrew Bland said in the AGM earlier, in terms of thanks to the team who've been involved in Goal Command and have been ensuring that we are responding in the way that we have been in South East London. So thank you, and we'll look forward to the update next time, Angela, on progress with flu vaccinations. I realise I'm running a little behind, but hopefully not too far behind. I'm going to hand over now, I think, to Farouk, just to speak to the paper that's been shared on inequalities. Is that right, Farouk?
Yes, thank you, Jonty. I'm Farouk Majid. I'm a GP from Lewisham and represent the governing body for equalities. I share this jointly with Joy Ellery, but my specific role is clinical lead for equalities. Now, people will be aware that our governing body has particularly taken seriously the issue about black health, particularly in relation to COVID, because of the disparities that have been highlighted. And Jonty, you mentioned some of this in the AGM earlier today. Now, it gives me really a great deal of hope and pleasure to see the depth of conviction really within our governing body members, but also the leadership and the way that we've approached and tackled some of the issues relating to this and the measures that we've taken, but also the issues that relate to the disparity in representation within our health services of different members of the population. So there's quite a lot of detail and quite a lot of work that's been done, and I'm going to hand over Christina shortly just to outline some of the details and some of the work plans that I've been watching develop and been part of. But what I wanted to do today was to just look a little bit wider around equality. So this is not just about making sure that people with protected characteristics are represented, or that one particular client group or population. And what's particularly become clear to me is that equality in its widest sense, in terms of healthcare outcomes, is only going to be delivered if we actually all work together. And this is why I'm so pleased really with the direction of progress towards the development of the ICS and collaboration of partners. And I was very interested to hear what Clive had to say. But there's some issues there. I mean, one of the things that he mentioned, which I completely agree with, is about standardization and standardization of processes across systems and across healthcare providers, which reduces duplication. But it's also about messaging. So I want to give one or two examples. So for instance, I had a patient who had a problem with abdominal symptoms, bowel symptoms. And one of the things that she said to me, some years later, after she had various operations and various complications, was that When I first went to hospital and I was sent away, and the doctor said to me as I was leaving, "What's your diet?" And I didn't think much of it. But then when I came home, I wondered what that means. What diet should I watch? Should I look at my food? Should I eat something particular? What shouldn't I eat? So that information was missing. And this is kind of exemplified in the conversation that Nancy had with Kay around urology. Now, what I've come to realize is that equality and outcome of health equality, I think, will be well delivered if we looked at our population. So I'm very interested in the way that we're looking at population health. So although standardization is one thing, the ICS really gives us an opportunity to look at how we might use science to again equalize things. And this is about our population and the way that big organizations conduct research in this country. So the clinicians will know that, for instance, certain populations, we will say, oh, they can use some of these drugs, but they can't use some other drugs, and it's related to race. We had an opportunity really to question some of these and the research that's carried out, because it is very relevant in the way, say, for instance, our population is characterized in terms of who has blood pressure, which medicines are used, whether people are diabetic, again, which medicines are used. But I think as an ICS, and particularly our big provider organisations with a research focus, that's a very really great opportunity that we could make use of. A couple of other things that I wanted to just point out is that in terms of equality of outcome, sometimes it's really the basic stuff that's important. And one of the things that we've alluded to today and earlier on again in terms of the AGM was patients seeking access and about general practice. And you've mentioned the role of access to digital services, but also those people who want to be seen face to face. But I think as a governing body, if we could look at this in terms of what people want, and that is information, and it's how they get that information. And there's lots of different ways. Just because we have been culturally conditioned to see our GPs and go to our practice isn't necessarily the best way long-term in providing care. So someone having to take a whole day off just to see a GP for 10 minutes isn't productive, really, in my view. And this is something I think we really need to get into detail through our patient participation groups and with the public, as well as our patients, to see how we deliver best health care. So this is a theme I wonder whether we might be able to develop, perhaps their governing body seminar in future, because it addresses some of the key inequalities that happen because of the way that information is given to people or not given to people and where they access it. So we might consider the voluntary sector, faith groups, patient champions, and a whole host of things that perhaps we've discussed. What's been great is that this governing body has taken up the challenge of equality and of patient engagement, and that we've fulfilled our promise of delivering the governing body seminar. We are now looking very closely at how our own staff makeup and representation within the CCG continues to develop and what steps we need to take. So the workforce race agenda is progressing. So I think we have a fantastic opportunity, particularly when we come to that discussion around the ICS governance and how, as a system, we might deliver equality. So sorry, that was a bit of a generalised amble, but I think what it does, it shows it opens up what equality means. And equality, there are many aspects to it. And in this role as clinical lead for equality, I am looking at the clinical aspects of it, including medicines use. So, I mean, we still know, for instance, that a third of patients that end up in hospital is because they don't use their medicines properly. And it's a direct contributor to admissions, and yet the messaging around that can improve the health of our population so significantly in terms of outcome. So I'll stop there, but may I just hand over to Christina perhaps now to just look at the details and the progress that we've made so far. Thank you.
Thanks, Farouk, and thank you for the breadth of perspective you're taking and the leadership you're offering. Christina, I am going to, just because it's only a short item on the agenda, and people have had the paper, if you could give us a few headlines, and then I know that we're looking for an endorsement and also Chair's action. So if you wanted to just take us through that.
Thank you. I'm going to keep it really brief and hopefully, yes, people have had a chance to read. There are essentially 4 areas that we give an update for, and looking really for endorsement for the progress made and comfort with kind of the actions that we've been taken, and also support that there's a particular action, which is we need to submit our RES plan at the end of October, and therefore looking for support that there'll be Chair's action from Jonty to approve it pre-submission. The 4 areas, though, that the paper touches on is governance, just to really make the group aware that we have added additional governance forums to ensure that we are able to oversee and maintain a significant pace on this important agenda. And that includes, in fact, engaging with our staff on a regular basis about what we're doing. Secondly, we are working more actively with the ICS. Sean Daniele has been appointed as the Population Health and Inequalities Lead across the ICS and King's Health Partners. And we've been working with him to map out the current priorities plans that exist across the ICS to understand what we can sort of take from that, what we can do consistently and what we can share. And the next step will be identifying and building some governance at an ICS level about how equalities is monitored. Thirdly, a significant focus has been on race equalities and specifically for our staff. There's a huge amount in inequalities that is about how we support our population, and a lot of that is related to working with other partners across the ICS. But our staff is something that we have sole responsibility for supporting, and we have committed to 10 specific actions that we're going to take to improve diversity. We've identified that it's black staff in grades 8B and above that we have the most underrepresentation. So we want to particularly focus on that, but we're also focusing on equalities as a whole. And in fact, we have those 10 recommendations, but we have used the equality specialists in the CSU to go through that plan in the context of what we need to do for RES and identify some other things that they think that we should be doing. That RES action plan has been engaged with the Beyond BAME group, is going for broader staff engagement. And then, as I mentioned, we would want to submit at the end of October and have the Equalities Committee, and then for Chair's action to sign it off before submission. And then the final thing that I just wanted to say is give assurance that race equalities isn't the only thing that we are looking at in equalities. We have a broad engagement, broad equalities plan, which we are pulling into a single place, and we will continue to report at every governing body on our progress on that. But also just in terms of what we're doing to support our staff, we have a staff engagement group of over 50, so that's more than 10% of our staff, and have had an initial conversation about other equalities groups that we should be establishing and getting volunteers to support that. So these are things like LGBTQ, age and ability, women and maternity and things like that. So that group has met initially, we'll be forming the subgroups and moving forward on that basis. So lots is happening. Hopefully people have had a chance to have a look, and really, as I say, just looking for endorsement as to the way we're moving forward and for that particular action on RES.
Thanks, Christina, and for all of the fantastic work that's gone on. I'm really pleased. This is a massive priority for the organisation, and I know we've had input from a range of people. Can I just check then if there are any questions, first of all, for Farouk or Christina in terms of the what's been outlined in the paper? I know governing body members have had input to the paper and reviewed it in advance, but are there any other questions? In that case, I'm going to, and again, this sounds like a negative way of framing it, but I think it's the only way to do it on this, which is to say, is there anyone who doesn't endorse the direction of travel? Good. I can. I'm seeing endorsement coming up in the chat function here, so it's clear that there's lots of support, and I think it demonstrates fantastically good work. And can I then also ask if there's anyone who is not happy for me to take chair's action in relation to the workplace race equality standard that we need to submit? Again, I'm not hearing anyone express a concern about that. So thank you very much indeed. Thank you for a great paper, and thank you for the work that's been going on. And I think particularly thank you for turning the kind of commitment that we talked about as a governing body into some very explicit actions. I think that's incredibly important. So thank you. Really great work. On that note, we will move on to the Accountable Officers report. And Andrew, I'm going to hand over to you. I'm running about 20 minutes late. I'm just saying that.
Okay. If you're sitting comfortably, I'll begin then, Chair. I take the paper entirely as read because if there are questions about it, I'd like to hear them. But I'm afraid the nature of the paper is such that what it covers, you've just heard, I think, in the agenda so far and the agenda to come, the vast majority of these areas I wanted to flag. So it was really to give them prominence. Flu, critically important and a much bigger challenge than previous years. I've called that out particularly, and I just want to just to draw your attention at the top of the second page of my report, just the additional challenge that we're actually looking at, and it's so important we rise to it. The other two items I was calling out, particularly before the borough updates, were our phase 3 planning response and our recovery planning that Annabelle's spoken to in depth. So I'll take questions, Chair. Absolutely no problem at all.
Thank you, and you're right. We've covered quite a lot of ground, but happy to take questions. Questions for Andrew, or of course in relation to individual borough updates as well. Any questions?
I think Mary has made a very good point about it, the quality of the report being good.
Yes, that's absolutely true. So Mary, thank you for that. Anyone got any particular questions for Andrew? I know we have covered quite a lot of this over the meeting already. Okay, in that case, I'm going to Andrew, I'm going to say thank you very much for such a thorough report, so thorough that it answers every question. And I think Mary's absolutely right. It's a great report, and good to have updates from the boroughs as well. So thank you very much indeed for that. In which case, I am going to move on to the report for the prime committees. So people will be aware that we receive this at every governing body meeting, and what always staggers me about this report is that it demonstrates the huge amount of work that goes on in our committees between these meetings. There's a massive list of different actions that are being taken. It's really important the governing body is aware of these. These are mainly taken in a delegated way across the committees in the organisation, but it's really good to see the breadth of work that's going on. And I wanted to thank all of those people on the governing body who I know are contributing to those various committees. But there are a couple of decisions that we need to make, that we need to approve. So I'm just going to ask Christina to take us to those.
Yeah, thanks, John T. So yeah, again, we can do it very briefly. If we just move, please, Simon, on to the relevant page. It's about the 4th page of the report. There's essentially 3 things to note for decision. So the first is some minor amendments were made to the schedule of matters delegated to officers. That's been included with this paper. Secondly, the SLP complex care business case was agreed at the Commissioning Strategy Committee and has come here for approval. Martin Wilkinson is attending if there are questions on that, but really just a couple of amendments were made just to really clarify the joint work that's being done between the CCG and local authority, and clarifying that public and patient groups will be engaged going forward. There are some remuneration committee decisions that need to be endorsed, but as always, these are confidential in nature because they pertain to individuals. So those will be done in part 2 of the governing body. And then the only thing to say, but it's a substantive separate agenda, is obviously the pathology work has been discussed through the Commissioning Strategy Committee and is brought here as well for decision, but that has an item all of its own. The rest is to note, so it's really just to check that the group are comfortable with those 3 items.
Thank you, Christina. So first of all, again, are there any questions in relation to these are all items obviously that have been discussed in other committees, so people will have participated in conversations there, but just wanted to check whether there's any further questions before moving to a decision. Not seeing any indication that people have further questions, in which case shall I take the 2 decisions independently. So the first one is the recommendation from the Integrated Governance and Performance Committee in relation to the schedule of matters delegated to officers. Is there anyone who does not approve that decision? Okay. Again, I'm sorry to do it in a sort of negative way, so there's sort of silence, but it's I can't think of a better way to do it at the moment. And then the Commissioning Strategy Committee considered the proposal around complex care and the business case. We had a long discussion about that at the time. So again, I just wanted to see whether there's anyone who does not support the recommendations from that committee. Excellent. Then I'm going to assume that both of those decisions are supported. We will come on in private conversation to the Remuneration Committee recommendations. But that's great. Thank you very much, Christina. Fantastic. And between you and Andrew, you are helping me catch up. I'm hugely appreciative. Thank you. I do then want to move on actually to the next item, which I think you are also going to speak to, which is the board assurance framework. So take your time.
Well, I was going to say, hopefully I can continue that trend. Wasn't really going to do a page turn or particularly focus on anything other than to just talk about a process and a couple of actions. So obviously the board assurance framework comes here every governing body, but it's also reviewed in detail at it's reviewed in the IGP as well, and there's discussion there about scoring, etc. So we'll obviously pause for if people have comments, but just to give assurance, it is also reviewed there, and so will be being reviewed in the next week, in fact, again. Just things to comment on from previously. There has been a question about whether the equalities risk is scored high enough, given the both prevalence, the difficulty to change. We discussed that briefly in IGP and in fact at last time as well, and have agreed that it feels an appropriate score based on the mitigations that we are putting in place and the focus on it, but clearly we'll be monitoring this really carefully. And then the only other thing that I wanted to say is as well as the kind of oversight of this through the IGP, we've also agreed to do some deep dives and discuss some of these in more detail. So again, there's a really good opportunity to discuss. Other than that, I'm going to take it. I'm sure people have read every page and enjoyed it all. And it's really just if there's any comments, questions or concerns, as I say, we'll be discussing it again in IGP.
Thank you, Christina, and it is a really critical document in terms of the way we work as a CCG, and as you say rightly, it has and continues to come to the Integrated Governance and Performance Committee for review. I think what's important for this group, therefore, is just to reflect on whether we feel it has appropriately quantified risk, and I wanted to open up therefore to questions, comments in relation to the register, and then we can just move again to support the risk register for September. Are there any questions for Christina or comments about the register or the way in which risks have been assessed? Okay, again, I'm not seeing anything coming up, so that's great. I think in that case, what I just want to do is to ask whether there's anyone who doesn't approve the BAF for September. Good. Again, I am assuming, given that there is no dissent, that that is supported. Christina, thanks so much for the hard work that you and the team do to continue to update that, and we'll review it again at IGP, as you say, very soon, next week. So that's great. Thank you. And we'll hand on now to Kate, I think, for the quality report. Kate.
Yeah, thanks, John T. So again, I'll take, as in tradition, we'll take the fact that people have read the report, and I'm just going to sort of pick out a few highlights. So the nursing quality report just provides an update on the reports and issues discussed at the quality subcommittee, a summary of the serious incidents reported during July and August, and just to give us a brief update on the consultation process that we have followed around the Quality in Nursing Directorate review. So just picking up here on the, so if you just go back one slide. So the subcommittee has met now for the second time. Currently, we've stood the Quality and Safety Subcommittee up on a bi-monthly basis. So it met on for the second time on the 13th of August and agreed the terms of reference, which were recommended and approved at the Integrated Governance and Performance Committee. I've just given some details there in terms of the areas that were discussed at that last committee, and would particularly just picking out the review of suicides reported by our mental health providers during the COVID period, because this has been an area of concern, although we are not seeing a significant increase in suicides. We are continuing to monitor this this very closely. If we can move to slide 3. So the committee also reviewed the findings and the recommendations of the Independent Medicines and Medical Device Safety Review, so the Cumberledge review, and those who have read that review will note that it has found a number of concerns within the healthcare system around disjointed, siloed and unresponsive working. The subcommittee did note the steps already taken in South East London in response to these issues raised by patients, and so we were informed around the monitoring mechanisms and processes for monitoring and auditing patient outcomes. And I would also just highlight the work that's being done by the new Quality in Nursing Directorate that's closely working with Health Watch and others to ensure that the patient voice is listened to and supports our work in improving quality and patient safety. Just moving on to slide 4. So we provide always in this report some updates on serious incidents recorded during the preceding months. So there were 93 SIs during July, in August, and this included one never event at GSTT, and I have provided some detail there around that that never event, which was around incorrectly administered blood transfusion, but just to reassure the patient remains well and has not shown any signs of transfusion reaction to date. The most common type of incident logged by acute providers during this period has been diagnostic incidents, including delays in meeting SI criteria, so including failure to act on test results, with 4 of such SIs being declared. There's no themes particularly, so we always go through the SIs, we look for themes. However, it's been noted that some of the SIs that we are seeing are due to admin errors, and so we are supporting trusts around processes being done to monitor and identify learning and impact on quality of care resulting from administrative errors. We move on. So this just takes me to the Quality and Nursing Directorate review. So we have actually closed now the Quality and Nursing Directorate. So that's been running for 28 days, and we are in the sort of process of producing the management response to that consultation. I've just kind of highlighted here some of the, so there's been extensive work done around reviewing this review of the Quality and Nursing Directorate, which was not in place when we merged the CCGs, because myself as the chief nurse wasn't appointed at that point, and then of course we started the work and then had the interruption of COVID. So we have now completed the review, we've held the consultation, and these are just the kind of areas in particular that we wanted to focus on within this review in terms of integrated working, looking at opportunities for a commonality of approach across South East London, so bringing all the good work together that happens in all of our boroughs, and ensuring that we are able to use that work to identify best practice, ways of working and driving efficiencies. We've sought to increase the leadership and support to the boroughs through this review. So many of the functions that the Quality and Nursing Directorate are responsible for remain in the boroughs, and that is the appropriate place for them to be. However, in increasing that leadership and support, we're able to ensure that across South East London we are meeting our statutory responsibilities. And then looking at equitable subject matter expert input, so that we have that support into all of the boroughs across South East London. And we have significantly managed through this review to increase the capacity across the Directorate to support the boroughs, and particularly focused on the ways of working with regards to quality and patient safety, as you would expect us to do. Next slide. And then particularly within this review, but also during the work of the last couple of months, I've been focusing with my 2 directors of quality on working with stakeholders and establishing the sort of key relationships that we will need going forward as we develop the Directorate, but also as we develop our ICS approach. So we are meeting regularly with the CQC, NHSEI, Health Education England and Health Watch, as well as meeting with other providers through sort of the chief nurse and quality routes. We have established these meetings, and I think they'll put us in a good place to move forward with our ICS developments. I think I will leave it there, but obviously happy to take any questions.
Thank you, Kate. It's a really helpful presentation. I'm not sure if I have a question so much as I just wanted to share. So we were talking yesterday, in fact yesterday morning, at the sort of system recovery group that we have as an ICS, about the increasing numbers of people we've got waiting quite a long time for procedures. And I suppose what I was really pleased to hear, so I sort of channeled you and asked what was happening in terms of ensuring that people were being kept well and prioritised accordingly. And I was very pleased to hear that all of the work that went on to establish essentially that sort of risk assessment process for everybody on the 52A list was still happening. They are talking now about going into a more detailed clinical validation process for the lists, just to ensure that they are able to manage some of those people who are waiting for a long time. I sort of wanted to share it. I don't know whether you've got further comments on that, but it feels as though it's something we should be paying kind of close attention to.
Yeah, no, absolutely. And I mean, one of the real strengths of the way that we have developed our directorate is to have our quality team very mirrored to our planning commissioning team. So we're working absolutely in partnership, and we are jointly doing that work with that team.
Thanks very much. Are there any other questions for Kate at all in relation to the work that's going on, the great work that's going on in developing our kind of quality approach and sort of organisation, but also any particular issues around quality of services being delivered? So again, Mary, did you want to come in?
Thank you, John T. I mean, just really to reflect, you know, the challenging times that we're all in, and the fantastic work that Kate and the team have been doing, you know, especially with, you know, trying to stand up a new structure as well. You know, this isn't easy, but, you know, they're doing a really good job. So just continuing to support as we move forward, really. Thank you.
Thanks, Mary. That's great. And I know many members of the governing body are quite close to this and quite involved. Again, fantastic. Kate, thank you very much indeed. So we are now going on to a paper on patient engagement. And I think Rosemary Watts, I'm hoping, has joined. Fantastic. Hi, Rosemary. Would you like to take the governing body through the headlines of this paper?
Thank you, John T. I'm Rosemary Watson. I'm the Assistant Director of Engagement for the CCG. This paper outlines some principles for engagement which the governing body is being asked to approve today, so that they can inform the engagement that will start taking place in the autumn. The principles have been developed with local people, specifically in two task and finish groups that we've set up: the digital engagement task and finish group and the non-digital engagement task and finish group. And we've also worked with two members of the governing body. Thank you. If you want to leave it on that page, which outlines some of the principles. We've worked with two members of the governing body as well. That's Joy Ellery, who, as many as you'll know, is the lay member for patient and public involvement, and Falake Shogun, who is the Health Watch representative, as well as local people from across the 6 boroughs. I won't highlight all the principles, but I will pull out some important ones, which is the importance of clarifying the purpose of engagement before any engagement activity, so people know what they're getting involved in and why. The importance of timeliness of engagement and the need to engage with people early. To recognise and address equality, diversity and inclusion issues, and to work with partners and to outreach so we can engage across the diverse communities of South East London and hear particularly from those who are seldom heard. And in relation to that, the importance of clear, accessible and culturally appropriate information. Members of the task and finish groups also felt very strongly that engagement is a key in helping the CCG build positive and ongoing relationships with local people, and that we need to listen and be responsive. So I just wanted to call those ones out. There were some particular specific principles which I think are either at the bottom of this page or on the top of the next page around digital engagement. Of course, since we started engaging on our engagement approach earlier on in the year, the world has changed a lot, and we are doing our engagement through mainly digital means at the moment. And some of the principles relating directly to digital engagement are the fact that they need to work across different platforms and devices so that our digital engagement can work on computers, iPads, smartphones, and they shouldn't incur any additional costs to local people. And in terms of non-digital engagement, it was clarified that we need to be aware of time sensitivity of any printed material, and also acknowledge the potential for engagement activity to be fun as well. As I've detailed in the paper as well, National Voices published 5 principles for engagement in June this year, particularly around the next phase of COVID response. And many of our engagement principles talk directly to the first 3 engagement principles of National Voices, which are to actively engage with those most impacted by change, to make everyone matter, leave no one behind, and to confront inequality head on. So the governing body's been asked to approve these principles today, pending the final work of the task and finish groups, which are setting up the Engagement Assurance Committee, which won't be in place yet, so that these can be approved to inform engagement that will be starting imminently. So that's just what I want to highlight from the paper. I don't know if anyone's got any questions.
Great, of course. Thank you, Rosemary. Thank you for kind of highlighting that, and thank you for the work that's gone on in developing those. Before I check.
Sorry, Jonty, I should just thank all people, all local people who worked incredibly hard with us over quite an intense series of meetings across July and August. And it was a lot of work. We had a lot of meetings, people contributed, and the quality of the contributions to from local people was excellent, and we just couldn't have got such a robust set of principles without everyone's contributions.
Thank you, and yeah, really helpful to see the work that has gone into that. I wanted just to see whether, but before we move to sort of endorse the principles that have been described, I wanted to see if people do have any questions. But first, Joy, I didn't know whether you also wanted to say a word or two. Obviously, you've been working closely on this as well. Was there anything that you wanted to say?
No, not in particular. I think Rosemary has presented it really well. The paper's really clear. I was just going to thank everybody as well, and to thank Rosemary and the engagement team for driving this work. But the quality of the contributions we've had, I think the understanding that we've built up amongst the people that have taken part, and the trust amongst the group, it's really emphasised to me how good it has been, this intense working, but working closely and developing something together. It's been a really good example of producing something together with members of the public and their contribution. So yes, I absolutely endorse this work. It allows us to include contributions from the boroughs, which are just so important for us to work very closely to the boroughs, to the PPGs, to the local as well as the larger scale work.
Thank you, Joy, very much indeed. And without wanting to put you on the spot, Falake, I know you're the other governing body member who's been very closely involved from Health Watch. I just wanted to double check whether there's anything you wanted to add.
Not really. Again, I can confirm that it has been lots of meetings and there's been really good positive contribution. It's been really good to see how open Rosemary and the team were also to the public contributions and comments, and including them in not just the papers but in the final terms of reference going forward for the Engagement Assurance Committee. It's a testimony to their openness. It's the principles have been agreed across all 3 groups, I think, or 4 groups really, as Rosemary has highlighted. And really, I look forward to making sure we're working with you to see that we deliver on those principles.
Thank you very much indeed, and we really welcome the partnership that we have with Health Watch. Thank you, Falake, that's great. So any other questions or comments? Neil, did you want to come in?
Yeah, Thank you very much.
Cool.
That would be really helpful. Thanks very much, Rosemary, for you and your team and all the work they're doing. Aware how important it is at this time. I guess one of my key questions, in Greenwich, Health Watch ran a particular event around Black Lives Matter and the BAME community. And I guess one of the key messages I heard from that was the importance of not the community coming to our meetings, but us going to them. And really doing that in a joined up way, and there's a really strong commitment to do that locally in Greenwich. I was just wondering if there's been any reflections on how we best do that. And then whilst I've got the microphone, just to comment, I know that the actual comms and engagement team members in Greenwich have changed recently as a result of the restructure. I'm delighted that Russell Cartwright and Juliana are now in post, and I'm expecting that they will go out and meet some of the people in Greenwich, because there'll be new faces for people.
Thanks, Neil. Rosemary, thoughts on that sort of going out to the community in particular? I think Neil specifically were also asking about Black and minority ethnic groups, right?
Yes.
Yeah.
Yes, absolutely. And there was quite a lot of discussion in the task and finish groups, and also in the COVID impact task and finish group as well, acknowledging the importance of working with partners and particularly voluntary and community sector groups, and to outreach and to reach out to those groups and those community leaders as well, to inform our engagement work. So I expect that we will be doing that across all the boroughs and centrally as well. And in fact, we've started talking to community leaders to gain insight for the imminent flu campaign as well as talking to people as part of the Black Lives Matters work. And as you know, I was part of that Greenwich event as well. But I think it is really key and very important.
Thanks, Rosemary. And of course, one of the we talked about this a little bit again at the AGM, the sort of opportunity that we're trying to create here between things that we can do collectively, but then also this is one of those areas where it's critical that this happens at a very, very local level with local community leaders, and that's why we're trying to kind of configure the organisation as a CCG so that it can respond both at that very, very local level, but also across South East London. So I think this engagement kind of function, if you like, is an exemplar of how we need to be able to be big and small in that way. So very much appreciated. I wanted to bring Peter in, who I think also wants to comment.
Thank you, John T. I think coupled with our equalities paper, which we received today, I think this demonstrates the strong commitment that the CCG has towards these important areas of collaboration and work. So I would like to add my thanks to Rosemary, Joy, and others who've been involved, and to support the principles. We're talking about the principles there. They're clearly outlined, and I feel those principles are worthy of the adoption and support of the CCG. Thank you.
Thank you, Peter.
Thank you.
Thank you very much indeed. So I am really kind of positive about the endorsement that this is receiving from people. I just do want to ask the question specifically whether there is anybody who would not approve the principles that have been described in this document. Okay, in that case, I am going to assume that this is supported unanimously, and of course it's important because now it's really important to progress to establishing some of the sort of mechanisms that we want to put in place around this. And I know, Rosemary, that you'll continue to work to do that. Thank you so much for the work that you've put into this, and I think we've heard tremendous endorsement of that around the governing body. So so thank you very much indeed.
Thank you.
Great. Okay, so we are now moving on to the next item on the agenda, which is the pathology programme, the ICS pathology programme. This is an item for decision, and I think I'm handing over to Usman to present this item. Thank you.
Thank you, John T. Just for those who don't know, I'm Usman Niazi. I'm the Chief Financial Officer for the CCG. So we're just going to discuss the paper set out in for the provision of pathology services and commissioning arrangements for that for 2021-22. I think just before I start, it's worth saying that I know we've discussed this with governing body members previously, and this was discussed in detail at the Commissioning Strategy Committee, who recommended this for approval to the board. So I won't go through the paper in detail, and I'll take it as read, but I will sort of bring out some key issues and key points that I just highlight so that everyone has a chance to focus on those, and then we'll take questions. So I suppose the first thing to say is this is the sort of end of a process. This isn't something we've sort of started new in this financial year. Many of you will be aware that the ICS, or as it was at the time, the STP, South East London STP, set up a pathology network back in 2017, responding to some of the national requirements. And at that point in 2018, we, as a whole STP with all our partners, agreed to commence a procurement exercise for pathology services. So this is sort of to highlight the end of sort of coming towards the end of that process. It's definitely worth highlighting that all 6 CCGs, as they were constituted at the time, were party to that procurement process, to the extent that all the direct access activity for the 6 CCGs as a group was included within that procurement process. Today specifically, we need to make a decision around the commissioning intentions and the commissioning arrangements for this activity for next year, and clearly that will also link to the end of this procurement process and then allow that process to conclude as well. So I think a number of specific points to highlight in section 3 of the paper. If that's all right, Simon, thank you. It just sets out some of the context, and I think, again, it's worth saying that this was a process that started back in 2018. All NHS partners, including all our providers and CCGs, were part of that South East London pathology network process. But as set out in section 3, in October 2018, LGT did decide not to be part of that process and withdrew. That decision aside, it did not impact the overall procurement, and the rest of South East London NHS partners, so the other 4 NHS trusts plus all 6 CCGs, continued with our procurement, and all our activity was contained within that procurement process. So there were no changes as a result of the decision of one of the partners to withdraw. The final decision to commission the activity through the new network provider was always subject to a final sort of value for money test, confirmation that from a CCG's perspective, we wouldn't be paying any more money than we currently are now, and indeed hope to generate savings as a result of that. And later on in this paper, you will see in section 6 that we've set out in a bit more detail the process that we've gone through to do that, and the confirmation that this new network provision not only won't cost us any more money, but will also save us some money, and hopefully will also save the system some money as well as we go forward. The decision to commission through the new network provision is relatively limited in its scope, and I say that just to be clear that this does not involve any service changes for patients or for GPs or primary care. So patients will continue to go to their current locations to, for example, have their bloods taken. GPs will continue to collect those samples, or those samples will continue to be collected from the same premises. and the tests will be reported in the same way, and people will be able to access those results in the same way. So I think it's important to highlight that the really only change here is where those tests are actually processed. So this is not a sort of service change as we would describe it, but it is really a sort of more back-end process in terms of where those tests are physically processed. And the final thing I just wanted to highlight before I go into some of the details around the financial position, we are only making a decision for the financial year 2021-2022. So while the overall procurement process, which is being done by GSTT and King's College Hospital as a partnership, maybe for a longer period of time, we as a CCG are only signing up to or making a decision for next financial year, and that any decisions after that or any for subsequent future financial years will be subject to the normal annual commissioning processes that we would make. So just going into a little bit more of the detail, in section 5 of this paper, we have just sort of briefly touched on some of the non-financial benefits. I mean, the main aim of this paper was just to give ourselves as a CCG and the board assurance that the new network provision will not cost us any more money, that it offers value for money, which I hope the paper sets out. But the section 5 does just highlight the fact that the proposed service is also high quality service in terms of the scoring that was carried out, and in section 5.2 we have listed out some of the benefits, in particular for primary care and for patients within South East London, of the new service for us. Section 6 of the paper just sets out what the financial benefits are and how we've gone about doing that. So I think it's just worth highlighting that the value for money assessment we've done has been as set out and sort of as we said we would do as part of the original procurement process. It's been done on a relatively simple basis, which is to compare the costs that the CCG or the CCGs as they were at the time were incurring against what we know we will incur next year if we were to proceed with this decision from the new network service providers. And on that basis, in section 3, you can see that in all scenarios, we've set out a range of scenarios, the CCG will make a financial saving. The reason there's a range of scenarios is I think we wanted to make sure that we were doing this in a prudent way. And so we have based all of our sort of assumptions and our savings assumptions on the sort of minimum sort of limited growth scenario, which is scenario A. Whereas I think the likely scenario, it's worth saying, will probably, as set out in the paper, will probably be higher than that, and therefore the savings the CCG would receive are likely to be higher than those set out in the minimum case. And finally, I think it's just worth highlighting that we have been doing this in partnership with our NHS partners who remained within the South East London pathology network, and through that process the CCG has been well represented through the whole procurement process, been part of the programme team, and we have also secured we've also been part of the process of making sure that we would get some financial savings out of this. So John, if it's all right, I'll stop there. I'm conscious there'll probably be some questions, and I know we're running a bit late as it is.
Thanks, Usman. Yeah, there may be questions from governing body members. So can I just check and see if we have anybody who would like to come in. I think Krishna, you were going to ask a question, and then I'll come to Clive, and then Joy. Yeah.
Thanks, John T. Thanks, Usman. That was a well-written paper. I want to ask a little bit more about the value for money, specifically around the 2% minimum, and then can be up to 5%, and based on the growth and all that. That calculation, is that a robust one? How confident are we that it's going to deliver, so that we have that taxpayers' money to spend on other essential services, which is what we have procured this for?
Thank you, Krishna. So I think great question. I think it's definitely worth saying that we've been conservative when we've looked through this, and we've done this in partnership with both trusts. We've been through sort of the financial scenarios, and I think it's worth saying that historically the growth that the CCG has seen in direct access pathology has been much higher than 2% in all our previous years. And just for context, prior to COVID, at the start of this year, we had anticipated there being 4% activity growth on primary care direct access pathology activity, and in that scenario we would have actually generated savings of 6%. And so the mechanisms by which we get those savings are clear and robust and will form part of our NHS contract with both trusts, and that's been agreed with both organisations. So I'm confident and assured that we have robust way of getting the savings, and that the calculation and the sort of methodology for those savings has been done as well.
Thank you. Sorry, it's this mute button, isn't it? Clive, yeah.
Thank you, Usman. Clive Jansen from Bexley. Just a question regarding the transition of the service, and I think it's just really important that secondary care have seamless access to the pathology, especially local to Bexley, QE and Lewisham. They have seamless access to the new service as well as historical blood results. And we maintain phlebotomy services in the community as well. And with that, I think we need to make sure that community teams also have seamless access to phlebotomy as they've done at the moment, including district nursing teams, mental health teams and anticoagulation. So I just wanted to raise that.
Thank you, Clive. So I think absolutely that is going to be the most important issue. If we do make a decision, ensuring service continuity, ensuring the transition and the mobilisation, clearly members will appreciate that until we've made the decision today as a governing body, we wouldn't sort of commence any transition planning. Pending the outcome of our decision today, and if we take on board the recommendations of the Clinical Strategy Committee, Commissioning Strategy Committee, then we would quickly stand up a transition board and transition and sort of implementation board to make sure that we oversee service continuity issues, implementation of the new system. And I think key amongst those, and I think hopefully some of you will have been part of the conversations with partners where we've had assurance around use of the same systems, continuity of service, and making sure that on day one of the transition, in effect for primary care and patients, nothing changes, and that people are able to access the same results, be able to order the same tests and come to the same places to have those tests.
Thanks, Usman. So I think the final question from Joy.
Yes, thank you very much, Usman. The financial considerations and expectations are very clear, but the quality of the service is just as important. And I haven't quite got enough of a feel for the process that was gone through. I wonder if you could just give us a little bit more detail on that, please.
Thanks, Joy. So I think, as I said, the CCG has been part of the programme board that's been evaluating the sort of procurement process and going through that. I think the companies that have been, the company that was picked and sort of the partner that will work with King's College Hospital and GSTT had the best clinical score of all the bidders in this process. And sort of for clarity, what that means is, in terms, they were reviewed in terms of their service model, their governance requirements, implementation ability, innovation, and quality standards. So I think on that basis, they scored the best of all of the bidders who were there, and the CCG was part of that. So we had clinical representation as part of that scoring panel, and have been involved in this through that whole process. So hopefully that gives you a bit of assurance in terms of the quality of the provider that's been picked to work with our NHS trusts.
Thanks very much, Usman. I'm not seeing anyone else asking to comment or ask any questions. in which case I think we need to move to a decision, and I just wanted again to do it in the negative, and ask if there is anyone on the governing body who does not support the decision around pathology service procurement. So I apologise. That's because my microphone's on that you're hearing something else come in on the computer. But I am not. I'm not seeing anybody share any further concerns, and so I'm going to assume that this is supported unanimously. And I do apologise for the additional noise. So great, thank you very much, Usman. Thank you for the work that's gone into this, because it's been a long process. I know that we're going to be reviewing it again in a year, but I think it's an important process, and it's important that we bring it to a conclusion at this point, and I'm delighted that the governing body have supported this. So thank you very much, and I will ask you to stay on, as it were, because I think you're now going to rapidly give us a finance report.
I am. You're all going to get sick of hearing me talk, right? Thanks, John T. So again, I will take the finance report as read and just go through it briefly. Simon, if you don't mind just bringing up the exec summary page. Yes, thank you very much. So this is the report for the period up till the end of July. I'm conscious, just because of timing and where we are in the month, that feels like quite a long time ago now. But as we was at the period of the end of the 31st of July for month 4, the CCG was reporting a year-to-date overspend of 11.5. Well, had a year-to-date overspend of 11.57 million, but we reported break-even. So members will be aware that in line with the new temporary financial framework that was put in place as a result of the pandemic, each month we report break-even position and then subsequently receive a retrospective top-up to ensure that that is in effect what happens. I can confirm that up until month 3, the CCG received all of the retrospective top-ups by and large that it asked for. There was £300,000 of the 17 million that we had previously asked for that was subject to a further clarification, which I believe has now happened as well. So subsequent to month 4, we have received that. So I can confirm we have received all the retrospective top-up funding up to the period of month 4 that we were expecting to receive. So that was good news. In terms of the specifics of the financial position, clearly the sort of national financial arrangements as they currently are and are still in place mean that the CCG has relatively limited ability to be flexible with the budget. A lot of our areas of spend have been nationally set while we go through this pandemic crisis. The main area sort of material overspend, which we have then subsequently received funding for, was related to COVID expenditure. And in month 4, we incurred another £8.5 million of COVID-related expenditure. Approximately 6 million of that related to sort of the discharge programme, so the hospital discharge programme that members will be aware of. That is to support us working with the local authority to rapidly get patients out of hospital beds and into either their own homes or into local care providers in nursing home or residential homes. So that programme has continued and makes up the bulk of the COVID spend that we've been incurring. We did still incur additional COVID expenditure related to sort of additional primary care costs in July, as we were still sort of in the process of maintaining some of our hot hubs that we had put up in place and stood up as a response to the pandemic. Outside of COVID, I think the 2 key things to highlight, which are relatively consistent with the previous months, were around prescribing. So I think the prescribing position has been pretty challenged since the start of the year, partly as a result of COVID-19, which has driven up some activity, but it's also driven up some unit prices for certain medications. So we've incurred additional pricing costs and had additional volume as well. And in terms of CHC, So the CHC element that's not related to COVID, we have had some overspends, and at month 4 reported a £1 million year-to-date overspend against that particular budget. I think it's worth saying we are reviewing the CHC budgets and working closely with the Chief Nursing Officer's team and local borough-based teams to make sure that we've got a really accurate, robust process for recording and reporting our non-COVID related CHC spend. I think it's fair to say the focus has been on the hospital discharge programme specifically at the earlier part of the year, and so we're now just going around to make sure that we've done all the work we need to around the CHC areas. I think beyond that, that's probably the key messages for the month. We have, I mean, since this report was written, had the month 5 position. I will save that for the next board meeting, but I would just say that the month 5 financial position for the CCG was reported on plan as well, at break even. The position was largely in line with the month 4 position. There was no particular changes and no unusual expenditures that were incurred that were different to what we've seen as a trend through the current position. And I will stop there, if that's all right, Chair.
Indeed, thanks Usman for that update. So I'm just going to see whether there are any specific questions for Usman in relation to the finance report. I'm not seeing any specific questions come up. Just let me check. So I am therefore going to assume, Usman, that governing body is happy to note the finance report for month 4 and move on. Thank you very much. That was really a helpful update. In which case we are now going to, and I apologise that we're running a little late, but we do have time for some further questions from members of the public. And I think I'm probably going to ask Christina again to just help choreograph this. Christina, do you want to take us through some specific questions? And I'm very happy to answer, but we can equally bring in other members of the governing body as well.
Thanks so much. Yeah, so we've had a couple of questions from Alex Camus, which I was going to sort of condense because I think there's probably 3 main points on them. So part of this, I think, is about travel, and particularly where patients might have to travel to different. He's used sort of the term APC units, but I guess different services, and how we might consider that basically, and how it might be managed. The second is about the use of telephone or video triage and positive feedback on that, and a question as to whether we might be increasing that. And also there's a question about some of the challenges relating to patient notes, and sometimes the need for individuals to carry their own information around, and whether therefore there is any plans to increase the sort of information exchange between different providers. So hopefully, Alex, that's a good summary of your questions. I think, John T, if you wouldn't mind kind of kicking us off in response.
Yes, so they will happen to be things quite close to my heart, so why don't I try and see where we go. So I think, Alex, in terms of the question that you've asked on travel, there's a couple of things just to be clear about. Although Clive was talking about the development of some proposals that would potentially see services moved to different parts of South East London to try to ensure that people can be kept safe during COVID. It's just important to be clear that at the moment there aren't any specific proposals to do that. The networks that are being developed across our acute provider collaborative, the clinical networks, I think he called out things like urology, general surgery, orthopedics, gynecology. They are working on those proposals as we speak. I think what I would want to flag is that certainly the engagement we've done across London indicates that whilst people are prepared to compromise on choice of where they access care, they were very clear that for the most vulnerable and those who have any disability, for example, that would prevent them or impact their ability to access those services, that we would need to put in place mitigation for that. So patient transport, for example, and I think that's incredibly important. So in any proposals that come certainly to this governing body, one of the things we always do is to ask for inequalities impact assessments. We want to absolutely understand that any of those changes won't drive further inequalities into our population as a result of them. I think the other thing to say is that we do have some experience of this in South East London, so we know that we've been able to develop a relationship between King's College Hospital and Orpington, where they've been able to create, if you like, an elective orthopaedic centre. People get a very good experience of care with great outcomes, and what they're able to do there is, whilst the surgery is done there, they actually continue to see consultants locally. So for those people who do have to travel, the point would be that we would absolutely still want them to have their surgical consultations and follow-up locally, and I think that's one of the things that you were very keen to ensure. So I would absolutely say that the experience in South East London that we've had so far of this has resulted in improvements in outcomes and a reduction in cancellations, for example, and we have been able to put transport on, and we've been able to arrange follow-ups more locally, which I think you were asking about. So in terms of telephone and video triage, this is definitely something that is going to continue through the pandemic, because it's really important to try to ensure that people go to the right place and that they're seen by the right person, and that we, wherever possible, reduce the amount of footfall through organisations that could result in greater transmission of the virus. Saying that, it's really important to equally be aware that the whole point of that triage process is to identify where people would benefit from a face-to-face consultation, and to ensure that people can come in and be seen by a GP or other clinician, for example, in primary care. We know that others like you have really appreciated the opportunity to consult remotely. It's been very convenient for a lot of people, but it isn't right for everyone. So this is something that sits alongside the ability to telephone, the ability to then book in for a face-to-face consultation, and it shouldn't be seen as the only way in which it's possible to connect with a clinician at the moment. But it is an important way of us trying to manage risk in the community, and as we start to see COVID numbers increase, I think it's going to become even more important again. In terms of sharing information, I couldn't agree with you more, and I think my GP colleagues would absolutely recognise that one of the biggest challenges we have very often is having a kind of an understanding of what has happened to people in different parts of the system. And one of the key underpinning enablers, if you like, for an integrated care system, which is what we've talked about progressing to, is the ability to share information and enable teams from different organisations and from different specialties to be able to work collectively together to support patients. That does require us to have access to people's records. What we've been able to put in place in South East London is the ability to see the records that are held on patients in different organisations. So in a couple of our boroughs, there's something called a local care record. In other boroughs, they have been able to connect up and create an information exchange using other technology. We're now bringing all of that together so that across South East London, no matter what organisation you're seen in, they will have access to information from other organisations. The information doesn't move anywhere, but there is the ability to see that information. We now then need to look at the next phase, which will be how we ensure that there is a single record, potentially, that many different people and organisations can contribute to. So that becomes a sort of single version of the truth, if you like. But that's the sort of next phase of the work that we're doing. I hope that's a helpful update, Christina.
Thank you, John T. Yes, I think a more comprehensive update than certainly I could have given, so hopefully that answered it. The next question that we have, some comment and question, is from Ray Warburton, who's well known to us. His question is about engagement, and so I was going to come to Joy to comment on this. So Ray is very supportive of the principles. He calls them excellent, which is great, but Ray is asking about sort of understanding and the demographics of individuals attending meetings and being representative of the community, and how we might go about that. wouldn't mind.
Yes, thank you, and thank you very much, Ray, and hello. Yes, I'm very pleased that you liked the principles. I absolutely agree with you. We do have to collect this information. When we were doing face-to-face engagement meetings, we obviously collected demographics of everybody there and would carry on that principle. We haven't done that for the people asking questions, and indeed some people like to ask anonymous questions at the governing body, and I think that's entirely appropriate if people want to do that. We've developed a monitoring form for the Engagement Assurance Committee so that we can monitor going forward. But I would very much, if you've got some experience or some good ideas, because I know you've done a lot of work on equalities, and we do overlap, a lot of the work with the Engagement Committee does overlap with the Equalities Committee as well. So I would very much like to touch base with you, Ray, if that's possible, if you've got some good experience that we could learn from. We're always willing to learn from other people.
Thanks so much, Ray.
Sorry, I finished. Sorry, John T, I finished.
No, that's great. No. I wasn't quite sure. So Christina and I are playing a kind of game of tag here, just to orchestrate the various questions. So I think Christina, you go.
Yeah, great. So there is another question that we've received about the pathology procurement and whether there has been engagement with members of the public on that. So I was going to come to Andrew, if that's okay.
Sorry, thank you, Christina. I wasn't directly involved in the procurement exercise, so I think the best I can do for today is ask Julie Lowe, who was our programme director, just to give a response of who was involved and who not, unless, of course, my colleagues can assist me today. But I don't mislead my answer. I don't know the exact answer.
Thanks, Andrew. And I know as well that as part of the next phase, there will be obviously a process of transition, and I understand that that transition process will include engagement as well. I don't know, John T, do we have time for one more question?
Yeah, I think we do. Yeah, do you have?
Thanks. There's a couple that have come in just at the last minute, but I'm going to suggest we have obviously made the commitment. If we can't cover all of the questions, we will provide responses afterwards. So we'll do that. But one question had come in about whether there had been any consideration at the time as we approached the 1st of April about whether we would stop our merger process based on what was happening with COVID, and I was going to comment on that if that's okay. So a huge amount of work had gone into the merger programme up right through the year, and it would have been difficult for us to achieve our objectives and run the CCG effectively without transitioning. As I'm sure people recognise, if a programme progresses a good deal through and then it's changed, actually it can be more destabilising to try and go back then forward. Having said that, we absolutely recognised and responded to the need to focus all of our resources on responding to the pandemic. We talked quite a few times in this session about gold teams and teams across boroughs and South East London that were focused on the pandemic. We redeployed a large amount of our staff, some externally to support our providers and others to make sure that we were really helping them to respond directly, but also internally to focus on work streams, on coordination, on things that were pandemic focused. So no, we did not plan to propose our merger, and I think we would all agree, certainly across the governing body, that that would have been more dangerous and difficult to do so. But we absolutely focused all of our resources on the pandemic and continue to do that for as long as is appropriate.
Thank you, Christina, very much indeed. And I genuinely, I think I've said this before, I think the response and the support and the coordination we've been able to offer has been as a result of our ability to work across the system in the way that we have. So I think frankly, I think had we not, we wouldn't have been in as good a position as we were in many ways to respond as we did. So thank you for that. Okay, good. There are a couple of other questions that have come in. We will always answer all of the questions, and we'll ensure that they're incorporated into the minutes of the meeting, as we did with the minutes of the last public governing body meeting that we had. We genuinely appreciate everybody joining us for this meeting and the contribution that you've all made. I very much hope that you will join us again in a couple of months. In the meantime, I'm just going to quickly double check to see if there's any other business from members of the governing body. I'm not seeing any. In that case, I will close the meeting, and thank you all very, very much indeed for your time this afternoon. Thank you.